Right. Okay, shall we start the class? Yeah, right. Okay, so today can give some individual attention to you. Okay, okay, right. Let's start. So urinary tract infection, guys. Okay, now this is a pediatric heavy topic. Okay, so majority of your cases throughout your MBBS you're going to meet in your pediatrics. Okay, however, adult population also very common, very common. Okay. So today, when we are going through the lesson, I will go through both aspects, right? We will go through a little bit of pediatrics, a little bit of adult medicine as well, right? Especially the treatments, the choice of drugs, right? These kind of things, right? Okay. UTI now. Okay. So today, nothing to be shy. Okay. There's a small group today, right? So you all can just unmute and talk. Okay. UTI. What do you all know about UTI, guys? Anything you all understand about UTI? What is the main organism that is causing urinary tract infections? The most common. Come on. Unmute. Don't be shy today. Today is a small group, right? So we can do a Sri Lankan students. You all have heard something called Kuppi, no? Small group studies. So we can do something like that. Come on, unmute and talk. What is the main? Is it mainly by bacteria, viruses, or fungi?
Bacteria.
Bacteria, right? We all know that. Good. Bacteria, right? How would you define urinary tract infections, guys? How would you all define urinary tract infections? Until I share the screen. Come on, just tell me something.
Infection and inflammation of the urinary tract.
Infection and inflammation of the urinary tract. Excellent. Here, guys, when you're having, can you see the screen? Everyone can see the screen, right? Okay. Give me a second. Second, guys. Sorry. This technology is getting too advanced. Okay. Right, look at this. Okay. So, as your note says, right? Infection and inflammation of the urinary tract. Guys, can you all see me on the side as well? Can you all see me on the side as well? Yeah? Okay, good. Okay. Right. Okay. So, infection and inflammation of the urinary tract. Here, guys, upper, lower, and both. Now, I hope you all have watched that supplementary video. We talked about the definitions of upper urinary tract and lower urinary tract, right? Basically, bladder and below, everything is lower, right? Above the level of the bladder is upper, right? And with actively proliferating organisms within the tract. Okay, right. So, definition-wise, nothing complex, right? Presentation, guys. Urinary tract infections can be acute or chronic. Now, the acute, this is our most common one. This is the one you're going to meet in the clinic, right? Patients are going to come and tell you, today morning they woke up, when they went to pee, it's burning, or whatever the manifestation. We'll talk about the clinical manifestations in a little bit. Chronic, guys, unlike other diseases, unlike the chronic states of other diseases. Now, you all know when we talk about a chronic disease, we mean a disease that has been persisting. The symptoms have been persisting for a long duration of time. When it comes to UTIs, guys, the chronic word is a little bit different, right? What do I mean by a little bit different? There are three special entities here, right? We are going to talk about something called a relapse, right? A relapsing urinary tract infection, right? There is something called a reinfection, right? A reinfection. And there is something called treatment failure, right? Treatment failure. So these are some of the entities in the chronic one for UTIs. Okay. Right. Then talking about epidemiology, guys, right? This is obviously one of the most common outpatient infections. You all are familiar with that, right? Most commonly in females. Females of reproductive age is the most common, guys, right? Females of reproductive age, most common. Even in the supplementary video, we talked about the anatomy and we talked about some reasons as to why this is the case, right? If you all haven't watched it, it's okay. Just later when you all are free, just check the YouTube video. Right. Now, here, guys, what I want you to know, females, guys, it's so common that statistically speaking, right? About 50% of all females will have, or what they say is must have at least one UTI in their lifetime, right? This is the case. This is the statistics, right? Okay. And then if you take postmenopausal, that is females of reproductive age. If you take postmenopausal women, at least 10% will complain that they have had a UTI within the last 1 year, right? This is statistics, right? That's how common it is in females. Okay. Right. Then, guys, again, just letting you all know, today also a little bit of problems with regards to electricity. If anything happens, just stay in the meeting. Don't leave. I will be back. Okay. Like yesterday, some beauty, we are in Sri Lanka, no? Right? So there are some issues, right? Okay. Every now and then. Right. Then, etiological agents, right? As you all mentioned, bacterial is the main common. Here, guys, look at this. E. coli. E. coli is the most common species that is causing this, guys. Actually, more than 80% of UTIs are caused by E. coli. Okay. And here, guys, you all might have heard. Now, E. coli, there are different variety of species, right? For the urinary tract infections, guys, there is one called UPEC, uropathogenic E. coli, right? Uropathogenic E. coli. This is the strain. Now, there is enterohemorrhagic E. coli. There are different forms of E. coli. Right? This UPEC is the most common one. Okay, most common one. Then we have this. E. coli is what? Gram positive or gram negative? Come on. E. coli? Huh? Satuni? Huh?
Gram negative.
Gram negative, right? Gram negative. Huh? If there is anyone who doesn't know this, huh? Okay. Right, okay, right. In school, you all have learned this in school. Right, Proteus species. There are these Proteus. There is this. It's a group of bacteria, guys. This Proteus. In that, there is one called Proteus. Write this down. Mirabilis. Right, Proteus mirabilis. This is the specific one, guy, who is known to cause this UTI. Right, this Proteus species, guys. These are facultative anaerobic species, right? And they are also again gram negative, right? Now, okay, that's enough about Proteus. We'll talk a little bit more about Proteus as we go through, right? Okay. Then this Staphylococcus saprophyticus, these big names, guys, okay, don't get scared. It's a Staphylococcal species, right? Gram-positive organism. This guy is known to cause, have you all heard the term honeymoon cystitis? Right? Honeymoon cystitis, right? What is cystitis, guys? What is cystitis? What is honeymoon? Everyone knows, no? What is cystitis? What is cystitis? Come on. Come on. Unmute and talk, guys. Today, not a large group, no? Come on. So don't be shy. Just unmute and talk. Shabib, what is cystitis?
Inflammation of the bladder.
Inflammation of the bladder. Excellent, right? So this honeymoon cystitis, just as the name suggests, guys, we usually see it in females who are coming, right? Who have just gone for their honeymoon. This is happening, guys, mainly due to repeated unprotected sexual activity, right? This is one of the main risk factors, right? Honeymoon cystitis. Okay, right. Enterococcus species. Then we have enterococcus species, right? Guys, if there is any issue regarding connection, just message one of the admins, anything, right? Okay, right. Enterococcus species is there, again, gram positive. Then we have Pseudomonas. Now, Shabib, you came for my recipe module held like 2 years back. Yeah, don't say no. Okay. Now, Pseudomonas species, right? We talked about some Pseudomonas related problems. Do you remember about pneumonia? Pseudomonas? Pneumonia. Okay. Do you remember Klebsiella pneumonia? Yeah. Okay. In Klebsiella pneumonia, what was one of the major? If you're suspecting a patient with Klebsiella pneumonia, what would those clinical features be? At least one very
Drink
alcoholic. Excellent. Okay. Anything else? Alcoholics. Yes. Do you remember we made a small mnemonic about the alcoholic patient going to the club? Guys, you all can remember this like this. These again out of the topic now. Today I'm going a little bit out of this to these areas also, so that you all can touch on these areas as well, right? Otherwise you all forget. Okay. So here just remember this Klebsiella pneumonia, guys. This is not a very common cause of pneumonia, right? Not very common, right? But when we do get it, there are some characteristic features. How I used to remember this is called, remember it as Klebsiella, right? Klebsiella. Okay. Club. This is an alcoholic guy going to the club, right? This is an alcoholic guy going to the club, right? So he's drunk, right? He's holding a bottle. You all can draw. I drew this picture, right? Some time back, right? Holding a bottle. And what I want you all to know is, guys, one thing, right, is you can draw his mouth open and he's sort of puking. After drinking a lot of alcohol, they tend to puke a lot, right? This is not actually puke, but what I want you all to know is this is drawn in red. They have this red currant jelly sputum, right? Okay. They have a red currant jelly sputum. And if you look at their chest x-ray, guys, we talked about something called a bulging fissure sign, right? Tabib, remember? Bulging fissure sign, right? Okay. So just remember those points, right? We'll talk about these later again in pneumonia, another chapter. Okay. Then this group B streptococcus, guys. GBS is group B streptococcus. Group B streptococcus, where do we see it in UTIs? What is the most common entity? Most common people who are affected by group B streptococcus. Care to venture a guess? In neonates, yes. In neonates, how? The neonate by himself?
Usually around 37 weeks of POA.
Yes, from the mother, right? So this is group B strep guys, BC. Good. That was Atif, yeah? Good. Group B strep guys, we see in pregnancy, specifically in the third trimester, right? So today we will talk about the specific managements for this, the management protocols for symptomatic and asymptomatic UTIs in pregnancy have changed, right? Recently from the RCOG guidelines. I will teach you all that. It has changed recently, okay? So we'll talk about that as well. Right. So these are the most common etiologic agents. Now we will come to the classification, guys. Now, classification, one thing you all already know, according to the location, right? Lower UTIs versus upper UTIs, you all already know. Lower UTI is everything bladder and below. So cystitis, plus or minus urethritis, and prostatitis in males, right? We'll talk about that as well. Upper UTI, pyelonephritis. This pyelonephritis, guys, we consider it an emergency. We'll talk about that and how to manage that. We'll talk. Okay. Then according to the severity, guys, we divide urinary tract infections into complicated and uncomplicated. What do I mean by that? Complicated. Let's first talk about uncomplicated. Uncomplicated, guys, by definition, write this down. Huh? By definition, there are a few points to know about uncomplicated UTIs. What are these uncomplicated UTIs? One thing, right? UTI, right, in a non-pregnant female of reproductive age, right? Okay. UTI is in a non-pregnant female of reproductive age. Okay. Then the next one, when it comes to this uncomplicated UTIs, right? Non-recurrent in nature. They are non-recurrent forms of UTI. Okay. And the third thing, guys, write down no other disease associations, right? What do I mean by this? No other disease associations, guys. For example, let's say we are getting a non-pregnant female coming in complaining of UTI. Non-pregnant female, we don't need to say it like that, right? Just a female, right? Of reproductive age coming in with complaining with manifestations of a UTI. Now, what if this patient also has diabetes? If the patient also has diabetes, that falls under a complicated UTI because that is a disease association. This is what I mean by no other disease association, right? They cannot have other chronic illnesses that pose a risk towards developing UTIs, right? And they cannot also have other anatomical deformities that pose a risk towards UTI. If they have anything like that, they fall into the complicated category, right? Otherwise, they are uncomplicated cases. So non-pregnant female of reproductive age, non-recurrent forms of UTI, and no other disease associations. All are none, no. Okay. Right. Then when we come to this complicated, right? This actually, guys, for the uncomplicated, if you read Harrison's, how they describe it is they describe all these points. And in Harrison's, under all of that, they mention it is a cause of misery, right? And not renal damage. Just a cause of misery, right? Just the patient is feeling pain and dissatisfaction, quality of life reduction. That's it. Okay. Right. Complicated UTIs. What are these complicated UTIs, guys? By definition, there are a few things here. Write these down, right? The first thing, for a complicated UTI, guys, usually upper UTIs, right? Upper UTIs, we consider them to be complicated, right? Usually all upper UTIs, we consider them as complicated. The next thing, any UTI, right, in an adult male, right? Now here we have how many adult males, right? If you all get a UTI, right? Doesn't matter how mild it is, it's complicated, right? We will talk about why. Okay. Right. Then UTI in pregnancy. Now in the uncomplicated list, what did we say? UTI in a non-pregnant female. So obviously if it is pregnancy, right? It's a complicated case, right? Pregnancy. Okay. And guys, another entity here, UTI in immunocompromised patients, right? Those are also complicated cases because it is very difficult to manage, right? To get the infection under control, right? And then again, recurrent UTIs, right? Recurrent UTIs. Okay. And the last one here, guys, UTI, right? In renal transplanted patients. That means someone who has the recipient, right? If there is a recipient who has received a renal transplant, who has received a kidney, and now he is getting a UTI, that's again a complicated case. Okay. Everyone good up to this point? Very simple. These are just facts, guys, right? These are just facts that I want you all to know, right? Right. Then, guys, now here I have put, we are going to talk about the physiology. I have put this normal host defense mechanism. This is what all of us have, guys, right? these normal, we are the hosts, right? We are hosting the pathogen to come into our body, right? And if these defense mechanisms are gone, right, the pathogen is going to be able to proliferate and infect us, right? So that is, these host defense mechanisms falls under the physiology. So we'll talk about urine osmolality, pH, normal urinary flow. We'll talk about all of these in a little. For a second, guys, let's just leave that and we'll come to the pathophysiology. We'll discuss it with that, okay? Right? We'll discuss it with that. Look at this pathophysiology. First thing I want you all to understand, guys, right? What should the pathogen first do? It should enter through your urethral orifice. It must enter your urinary tract, right? This is what we call a ascending infection, guys. 99% of our UTIs are by ascending infections, right? It is not that there is a pathogen inside your body that is coming into the urinary tract somehow. No. Usually what is happening is pathogens from outside, from the urethral orifice, from outside, ascends upwards and comes to a urethra and then to the bladder and even above that level. Okay, so ascending infection is our most common. It's the most common mechanism or mode of pathogen entry, right? And for this ascending infection, guys, where is the most common site from that the pathogen is coming? Where from? From next door uncle? Huh? Or next door auntie? Huh? No. From the, we talked about this in the short video. I hope you all watched, right? From the anal region, right? It's just that pathogen itself travels that distance. Okay, right? That is the most common. True, there are other forms of infection. We'll talk about the other risk factors, right? Even these bubble baths and everything is there. But still, right? These are the main things I want you all to understand. Then, guys, this hematogenous or lymphatic spread, it's not very common, guys, right? From the blood coming into the kidneys or pathogens, right? Not very common. STIs, sexually transmitted infections. Now tell me this. Is this statement true or false? All UTIs are STDs. All urinary tract infections are sexually transmitted diseases. Come on, true or false? I see you all nodding your head, okay? So false, right? False. Okay. Then tell me if this statement is true or false. Urinary tract infections can be acquired via sexual transmission routes. True or false? True, right? True, good. So I can see you all nodding your head. So everyone understands this concept. We don't classify urinary tract infections under STD, guys. But from sexual activity, the pathogens that are causing UTI can go from one person to another, right? Just because the pathogen goes doesn't mean that that other person will get the UTI, right? We will see what factors need to be there for someone to get a UTI, okay? So that's very important. Right, then the pathogen, let's take a look at this defective host mechanisms and this host defense mechanisms and this highly virulent species. What is happening here? Look at this, guys. When we take a look at the pathogen's action in our body, right? One thing is the virulence of the organism. What is this virulence, guys? What does the term virulence mean? How easily a pathogen can cause a disease in our body. That is what virulence means. Okay, how easily a pathogen can cause disease. Now, in the UTI, guys, virulence is determined by some important factors. One, right, write down. One important factor is how well the organism can attach to the urinary epithelium and colonize it. Look at this, guys. Now, what I want you all to imagine is, right, imagine like a waterfall, right? This is a mountain and the water stream is coming and the water stream is dropping down like this. This is a waterfall, okay? A waterfall. Now, this is kind of like our urinary tract. Just bear with me. I will draw it properly. Okay. What is the goal of the pathogen? The pathogen starts at the orifice, at the very bottom. He starts at the bottom and he has to now ascend upwards. He has to ascend upwards, right? So imagine it like a competition. He has to go. There are flags at each of these points. If he reaches the very top, he wins, right? This is the same challenge our pathogen has, right? The more strongly, now all this water is gushing down and hitting the pathogen, right? As he's moving up through this, as he's moving up, this water is coming and hitting on his face, trying to drop him down, right? This is the same thing that is happening, guys. The organism, as long as it can attach to and colonize within the urothelium, right? The epithelium, right? Then he's going to be successful. So the more strongly they can attach to the urinary epithelium, the higher the virulence, the higher the virulence. Okay. Did everyone understand this concept? Right? Okay. Right. So like a waterfall, you all can keep it like that. Then to attach like this, to attach strongly to the urinary epithelium, these pathogens, guys, especially these bacteria, they have some special features you all have talked about, right? In your first, second years, right? The fimbriae, right? The pili, right? The flagella to swim, right? All of these structures are there. Apart from that, guys, you all know these bacteria, they can also release these exotoxins and these endotoxins, right? These also, exotoxins, you all might have heard something called hemolysin, right? Hemolysin, right? Okay. They can cause lysis of RBCs. Then we have endotoxins, the O antigens, the lipopolysaccharides, right? These kind of things are also there. We'll talk about how they are adding to the virulence. Okay. All of these things, they add to the virulence. Okay. Right. Then we'll take a look at this defective host defense mechanisms. What are these? Look at this, guys. If we talk one by one, right? Let me come here. Right. Okay. Let's start with this. Urine osmolarity. What is osmolarity, guys? What is osmolarity? Come on. Huh? What is osmolarity? Is it how? What is the unit we use for osmolarity, guys? Per liter or per kilogram?
Per liter.
Osmolality. Lality, not larity. Lality is milliosmoles per kilogram. Okay. The larity, R-I-T-Y, that is milliosmoles per liter. Okay. This is the amount, the concentration per kilogram. Okay. So now imagine this. We are talking about urine osmolarity. You all know, guys, what is the function of our kidneys? To concentrate the urine and produce as much concentrated urine as possible for the purpose of excretion, right? Because we don't want all the water that we are drinking to be gone out within the next hour, right? We are going to save all that water and try and remove as much as possible only the waste products, right? So that's the function of our kidneys, to concentrate. Now, what is our normal urine osmolarity, guys? Our normal urine osmolarity is what? What is the range? Come on. What do you all think?
Around 500 to 900.
Excellent. 500. Yes, around, close. Yeah, very close, right? Around, we say 350 to 400 is the lower cutoff, right? To about 950, sometimes they say 1000 also, some books say 1000 also, right? Usually 400 to 900, yes, 500 to 900 also, okay, right? On average, guys, we say around 600. We say around 600 is the average value. Around 600 is the average value, right? So now, what is happening when you're dehydrated? When you're dehydrated, your urine osmolarity goes towards this 900 side, right? It's increasing, right? The concentration of your urine is increasing, right? Within the liquid, more particles, right? Milliosmoles. Okay, right? Now, usually, guys, what they have found out was osmolalities, right? Osmolalities which are within the range of 750, right? 750 to about 900. 750 to about, this is quite high osmolarities, right? Whenever your urine has around 750 to 900, this is unfavorable for bacteria. What is happening here, guys? If we take a look at this sample, right? Let's say, okay, there is a pathogen inside. There's a bacterium inside. And now the urine osmolarity is high, right? Urine osmolarity is high, right? Okay, urine osmolarity is high. When the urine osmolarity is high, around 750 to 900 milliosmoles per kilogram, what is happening, guys? The bacteria, you all have studied about diffusion and osmosis, right? Okay, so when the concentration outside is high, right, of solute, the bacterium will start losing water, right? Water starts leaving the bacterium and coming into this medium. Okay, right? Loss of water. When the bacterium loses water, what happens, guys? The cell size reduces, cell division rates of the bacterium reduces, bacterial colonization, we call it biomass of the bacterium reduces, right? And their overall survival drops, right? Okay, so this is one protective mechanism, because you know our normal urine concentration, we maintain it around 400 to 900 and around 600 on average. And when we, most of the time, guys, right, how many of you all are keeping a water bottle near yourselves and drinking throughout the day? Any good students? Anyone? See, I have the same issue, right? I also don't drink a lot of water, right? But so usually, guys, the majority of the patients, even in the clinical setup, you will see their urine osmolarity is usually around 800, right? That is normal range, but it is bad for the bacteria. It is bad. Bacteria don't like it. Once it's exceeding 750, the bacteria don't like it, right? Okay, everyone clear with this, right? Okay, then. So this is what we call, the bacteria is undergoing something called hyperosmotic stress. You all can write it down. Hyperosmotic stress, right? So the fellow is going to die. Okay. The next thing, pH. Look at this, guys. pH is also a little bit of a similar concept. Let's take a look, right? When we talk pH, guys, what is the normal urinary pH? Now, if you all look at, like Gannon's physiology, right? They mention, guys, the range is 4.8 to 8.0. the pH. Now, this can vary from person to person, but the general range, we take it as 4.8 to 8.0, urinary pH. On average, we say it's about 6.0, right? On average. Here, what I want you all to know, guys, right? pHs of 6 to 7, right? pHs of 6 to 7 are ideal for bacterial growth. Ideal. Bacteria like this pH. So any pH that is less than 6, or any pH that is greater than 7, right? Greater than 7. Greater than is the other way, right? Okay, greater than 7, right? Any pH that is greater than 7. This is going to be a problem for pathogens. They don't like that. 6 to 7 is their perfect pH. Less than 6, they don't like. More than 7, they don't like. Okay, right. So if we take a look at what is happening here, guys, you all can draw something like this, right? Let's draw, right, something like this. Let's draw two boxes, right? And let's put a pathogen inside, right? And another guy inside here. And we'll say one is, I will color it in red, right? This is a little bit of acidic urine, right? pH is less than, let's say less than 6, right? And then the next one, I will draw it a little bit basic, something like this, right? This is pH greater than 7. Okay. These are the pHs that the bacterium doesn't like, right? When the pH is less than 6 or greater than 7, guys, one thing that can happen, look at this. One thing that can happen in both these scenarios is there is direct damage to the bacterial cellular structures, right? And the bacterial enzymes will get denatured, right? So overall survival will be reduced. Specifically, if we are talking about the more acidic pHs of the urine, guys, here what is going to happen when acid is high, guys, glycolytic pathways start dropping. What is glycolysis? What is glycolysis? Huh? Come on. What is glycolysis?
Breakdown of glucose.
Breakdown of glucose to form. What are we forming?
CO2 and H2O.
Oh, CO2 and H2. Okay. Anything else? That's some waste products, no?
ATP.
ATP is the side product. Pyruvate, right? Glycolysis is glucose being good, right? Glucose. So I will tell you all a story, right? So I was initially at Bangladesh, right? For my MBBS, right? And here, so in my biochemistry final, so they have vivas there, right? In Bangladesh. This is before Nanjing, right? So there we have vivas for the final viva, second year, right? For my biochemistry viva, first year. This is first year. For the biochemistry viva, the question there, so you all know, we have to wear shirts and ties and everything when we are going for these viva exams, right? So when I went, the question was, can you tell me the glycolysis pathway in reverse? Now you're at the viva exam, sweating with the tie on. When they ask glycolysis in reverse, what are you going to tell? I couldn't answer anything, guys. Actually, I failed that exam. There were 3 examiners, right? All 3 of them, they didn't give me a chance, right? They asked questions about vitamins. They asked all these, everything I answered. Just that one question I couldn't, right? So anyway, I failed the exam there, but I had to repeat it. Not an issue. But what I'm saying is, what were they looking for? What is glycolysis backwards? Gluconeogenesis, right? Gluconeogenesis, right? They just wanted to, right, mess around with me a little. We'll never forget glycolysis again, right? Glucose being broken down into pyruvate. ATP is produced. Okay, right. So, so when the bacterial glycolytic pathways cannot function, what is going to happen? Again, growth retardation, biomass formation reduces, right? They're going to eventually die, right? Okay. This basic pH, right? Or more alkaline pH. What is happening when there is an alkaline pH surrounding the bacterium, guys? The bacterium will start losing H+ ions, right? Because the bacterium has hydrogen ions as well. No? The bacterium will start losing H+ ions to the surrounding. Okay, to the surrounding, right? When H+ ions leave the surrounding, now you all know, guys, bacteria. When we consider the DNA structure of bacteria, what is it like? They also have double-stranded DNA, right? True, they have a nuclear structure, they have a plasmid, right? There are some differences compared to our normal cells, but they also have double-stranded DNA. Now, you all know in double-stranded DNA, guys, it's something like this, no? Right? And there are these base pairs, right? You all have heard of A, adenine, thymine, guanine, cytosine, right? A always with T, right? G always with C, right? I hope you all remember these, right? First year, second year work. How are these base pairs bound together, guys? How are they staying like this, bound together? How are they maintaining this structure, this double helix structure? What is holding them together? Hydrogen bonds, right? So now when the bacterium is losing these hydrogen bonds, what is going to happen, guys? They're losing hydrogen ions, so they cannot maintain these hydrogen bonds. what is going to happen? Their DNA structure starts breaking down. Okay, when bacterial, so this is your directly, the bacterium is being killed from the inside itself. At the DNA level, you're killing the fellow. Okay, so when there is basic urine, this is the other reason why bacteria doesn't like the pHs of above 7. Okay, above 7. Right? Okay, is everyone clear about this? Give me a thumbs up. Let me see some faces. Right? Okay, excellent, excellent. Right, then here, guys, just before we move on, I will mention one thing. Since do we have any first and second years? No, Dinitha is third year. Dinitha, right? Third year, it's okay. Everyone else is above fourth and fifth. Yeah. Imesh, which year? Imesh Dasnaik, fifth year. 5. Excellent. Okay. Right. Look at this. Here, guys, just to mention, you all can just put this as a side note. This acidic and the basic condition. This is applicable. This fact that I told you all, right? Because otherwise, I feel like you all might confuse this later on. Is less than 6 and greater than 7. We said the bacteria doesn't like. Except there are exceptions to this. Except, guys, there are some bacteria. There's one called acidophilic bacteria, and there's basophilic bacteria. Right? Just like the name says. What does it mean? Acidophilic. They love acidic environment. Basophilic. They love the basic environment. Right? Okay. So there are some species that this rule doesn't apply to. Okay. And we are not going to talk about the names of those species. Not really necessary. Just know there are some species. The other important thing I want you all to know is, guys, E. coli. Our most common pathogen that is causing UTI. This guy, some forms of E. coli, guys, especially the entero, the one we talked about, right? The uropathogenic, UPEC. These guys, they have some special compensatory mechanisms to help and neutralize the surrounding pH. So whatever the surrounding pH is, E. coli have the ability to bring it back down to this 6 to 7 range. Okay, this is one special ability that they have. That is one of the reasons why they're one of the most common, right? Okay, right? So just some additional points. Okay, right. Then we'll come to the next thing, guys. Normal urinary flow and stream. What do I mean by this? Look at this. Make this tiny. Now, this is our waterfall. This is our waterfall, right? Part of our waterfall. What did we say, guys? There has to be a good stream, right? Usually, guys, when we say good stream, what we are meaning is a good flow, right? Good flow and downward, right? If there is a backward or upward flow, again problem, right? Again problem, right? So there should be a downwards flow and there should be a good satisfactory stream, right? To help and wash out the bacteria. Now, what is happening if there is poor flow, guys, or a poor stream? There is going to be what we call stasis, right? Stasis, right? Urinary stasis. Now, what is happening when there is urinary stasis? The pathogens cannot be washed out. Now, we talked about how the pathogen has to climb through that mountain. We talked about, right? So now when the stream is poor, there is nothing to wash this guy down, right? Out with, right? So what is going to happen? Colonization can increase and the chance of infection and inflammation increases. Here, guys, we need to mention some conditions that can give rise to urinary stasis. What are these conditions? One of the most important ones I want you all to know is, guys, pregnancy, right? Pregnancy. Pregnancy is a cause of urinary stasis. Okay. So you all know. Now, in the short video that I posted for you all to watch before the class, there we talked about how the uterus is situated, right? The anteverted and the anteflexed uterus, it is situated just above the bladder, right? Now, what is the important thing here, guys? In pregnancy, how do you all think? Come up with some hypothesis. How does the pregnant or the gravid uterus cause urinary stasis? What do you all think? What do you all think? Unmute and tell me something. Tell. I'm drawing a diagram just to explain it to you all. But you all can unmute and tell me. This is the front view that I've drawn. Right? Come on. The green is the uterus, just above. It's just above. The bladder is the red. Okay. How? Guys. Come on. Dinitha, what do you all think? What do you think? How is in pregnancy, how is it causing urinary stasis or the poor stream or the poor flow? Just come up with any hypothesis. There are no wrong answers here. Come on.
That uterus will push against the ureter.
Excellent. Here, what I want you all to know, guys, right? When the gravid uterus is expanding, as the gestational age increases, the baby is growing bigger and bigger and bigger. As the gravid uterus expands, guys, it does not expand downwards like this onto the bladder. It does not, right? How it expands is it expands upwards like this, right? This is how the graviduterus expands. And here what is going to happen? It's going to hit the ureters. It's going to hit the ureters. This is how stasis occurs. Oh, okay, in pregnancy, right? Don't confuse this. Don't imagine that it is going to compress the bladder. There is a little bit of compression on the bladder. This is why the storage function reduces. Storage function, this is why pregnant females, they always want to go to the washroom. There is a little bit. But how the stasis occurs is, guys, compression of the ureters. Okay, don't mix up the two, right? Okay. Then the next thing. Again, in pregnancy, guys, so that is one reason in pregnancy. Another reason when it comes to pregnancy, guys, we know progesterone. Right now, with pregnancy, all these levels of hormones are going to increase in the body, right? When progesterone increases, guys, progesterone has a role to play in ureter dilation. It causes ureter, not urethra, ureter, right? Ureteric dilation, right? Dilation. Now what do you all think? Imagine a hose, right? Your garden hose, right? If you have a very large garden hose and you're still connected to the same tap, what is going to happen, guys? Very large diameter, the pressure is going to drop, right? Same in the ureter. When the ureter is dilated, as the urine is flowing through it, the pressure is lower. Right? So when the pressure drops, guys, the urine flow rate reduces. So that is another risk for stasis. Apart from that, guys, right, with progesterone, there is also a detrusor. Now, we talked about the detrusor muscle in the short video. I hope you all have watched it, right? If not, just check it out after the class, right? Smooth muscle relaxation, right? Due to progesterone, there is detrusor smooth muscle relaxation. So the bladder contractility, right? Contractility of the bladder, right, reduces. Right? So now, what do we know about pregnancy, guys? Mainly there is a compression of the ureter, so there is stasis. There is some amount of compression towards the bladder. Therefore, the storage function is reduced. Therefore, the mother will always want to go to the washroom, right? Very frequently, they want to go to the washroom. The other thing about pregnancy is when they do go to the washroom, right, and when they are urinating, their bladder won't fully contract because these detrusor smooth muscles are not functioning properly because of the progesterone. So even when they go to the washroom, they won't fully empty their bladder. There will be a remaining volume, a residual volume there in pregnancy. Okay, so all of these combined gives rise to stasis or giving a high risk for urinary tract infections in pregnancy. Okay, everyone clear? Right? Right. Then, so pregnancy is one. What is the second one? The second one I want to talk about is, guys, urinary tract obstruction, what we call obstructive uropathies, right? This is now surgical topics, right? These are surgical topics, right? Obstructive uropathies. What are these, guys? We are not going to talk about much here. In males, you all might have heard something called benign prostatic hyperplasia, right? Benign prostatic hyperplasia. Then there are certain carcinomas. That can cause obstruction, right? These are the main, the tumors and BPH are the main two that I want you all to know here, right? We are not going to talk too much, but what I want you all to know, they are going to obstruct whichever part of the urinary tract, right? They are close by, right? And they are going to cause stasis, right? Okay. Then the next one is, guys, this one is interesting. Write this down. Spinal cord injury, right? Now, so for this, to understand spinal cord injury, guys, we need to talk a little bit about the sympathetic nervous system and its effects on urination. Look at this. Now, usually if we take the spinal cord, guys, I will write it somewhere here, right? If we take the spinal cord, right? The sympathetic outflow, guys, from around the thoracic 10th to around the thoracic, around the lumbar third, T10 to L3, around this level, guys, we get the sympathetic outflow coming to the bladder, right? The sympathetic outflow coming to the bladder. This is why, what is the nerve, guys? Have you all heard the nerve? Hypogastric nerve, right? Hypogastric. This is sympathetic supply to the bladder, right? Okay, sympathetic supply to the bladder. Now, what does sympathetic supply to the bladder do, guys? It helps in detrusor muscle relaxation, right? Sympathetic supply, right? Detrusor muscle, detrusor relaxation. Then, from the spinal cord again, right? Around the sacral, from the sacral, around S2 to S4, we get the parasympathetic supply coming in, right? The parasympathetic supply. This is the parasympathetic supply. What is the function, right? Parasympathetic. This guy is detrusor contraction, detrusor muscle contraction. Now tell me this, guys. What happens when the detrusor is relaxed? What are we doing with regards to our urine? Come on. detrusor muscle relaxation. What are we doing? What is happening to the urine?
Storage.
Storage of urine. Excellent. Detrusor muscle contraction is our micturition or our urination, right? Now tell me this. Is it right that when we have a sympathetic signals coming in that we need to store urine, and when we have parasympathetic system, we need to void the urine? Is that the correct way it should be? What do you all think? Yes or no? Come on. Lula, what do you think? Do we need the detrusor muscle relaxation or the storage of urine in the bladder during a sympathetic supply coming in? Or do we need it the other way around? What do you all think? Now think like this, guys. Okay, good. It's okay. Think like this. Sympathetic. Now you all know in our fight or flight, you all know our fight or flight action, right? Where with the adrenaline surges, this is from our sympathetic system, right? Sympathetic system. Let's say, right, you meet an enemy, right? One of your enemies, right? On the road. Now you want to fight him. So your sympathetic system, your heart rate is going to be elevated. You're going to have your, pupils are going to be dilated, right? You're getting into the fight mode. When your sympathetic system is stimulated like this, when you're trying to get into the fight with the guy, do you want to be urinating? Should we be urinating? No, right? Okay. Even if you feel the urge, you want to somehow hide it, right? So we don't want to relax we don't want to contract our detrusor muscle and urinate. So that is why during the sympathetic outflow, we are getting signals to relax the detrusor muscle and store as much urine as possible. In the parasympathetic system, opposite, right? When you go to the washroom, your parasympathetic system is activated, then your detrusor muscle will contract and push the urine down. Okay. This is the job of the sympathetic outflow and the parasympathetic outflow. Having said this, guys, there is also another phenomenon I want you all to know, don't get yourselves confused with this. You all have noticed when you all are going to write exams, right? Just before the exam, like 2 minutes before the paper starts, you feel the urge to go and urinate, right? You feel the urge to go and urinate, and you go run quick to the washroom and come back and sit down and start the paper. Why does that happen, guys? That is because now, just before the exam, your heart is racing or your sympathetic nervous system is going to be activated, right? Because you're getting into this mode to try and attack the paper, right? That is actually what is happening, right? Not to physically attack the paper, but to take up the challenge, right? So your sympathetic nervous system is going to be activated. The sympathetic nervous system, guys, true, it helps in bladder relaxation and storage of the urine. At the same time, it increases your heart rate, it increases your renal functions, right? We are going to talk about glomerular filtration rate and all of that in a different chapter, in nephrology. But basically what is happening is all of these body's metabolic processes increase with your sympathetic nervous system activation, right? Therefore, what is happening? Urine production increases. Urine production also increases. So what is the sympathetic nervous system doing? One thing is urine storage, also urine production. This is why just before the exam, you feel the urge, right? You have a full bladder. You feel like, okay, my bladder is full, right? But doesn't mean you're going to leak urine. Huh? There is no problem. There is no sudden detrusor contraction or something like that, right? You can store your urine, just that you feel the need to urinate. Okay. So just remember those functions of the sympathetic nervous system. Now, once you understand that, guys, right, when we have spinal cord injury, right, especially at these sacral levels, what is going to happen, guys, right? The micturition reflex will not work properly, right? The micturition reflex will not work properly. Therefore, there can be urinary stasis, right? The detrusor contractions won't occur properly. Therefore, there will be a residual volume remaining in the bladder, even when you're urinating. This is very common, guys. You all might have heard, sometime back now, Manari, did you initially come to this UTI class, which was held like a couple of years back? Were you there? Okay. I think I might have mentioned there as well about what happened sometime back in Sri Lanka, right? Long time back, actually. Now that was 3 years ago and way before that, right? These things don't happen now, but what happened was, so there was a motor vehicle accident, and the patient, he was brought to the hospital. He died. The cause of death they found out was bladder rupture. Right? And what they found out was what had happened. There was spinal cord injury. There was sacral plexus injury, right? And, right, they hadn't found it out on time. They were managing his other problems, right? And the bladder rupture. Now, these days, these won't happen, guys. Our emergency care units are very good, right? In Sri Lanka. But this is long time ago, right? Okay. This happened, right? So this is about the spinal cord injury, right? Then, guys, we'll come to this next point, urothelium. Now, we have mentioned a few points about this urothelium in our introductory class as well. They are, guys, in the urothelium. What are the layers we talked about? we talked about at the bottom, the basal cells, right? These cuboidal cells, and the intermediate layer. We talked about a little bit of these columnar cells. And on the very top, we had the umbrella cells, right? I hope you all remember. And on the umbrella cell, if you all haven't watched, just go and check, no problem, right? It's okay, right? It's available on YouTube. Look at this. This umbrella cell layer, guys, on the top, what did we say, Prashan? Glycose aminoglycan, GAG, right? Glycose aminoglycan layer, right? Now, so this is a mucus-like layer, guys. This is a mucus-like layer that is present on top of these umbrella cells. Now, this is on the luminal aspect. Now, if I take a cross-section of the proximal part of the urethra, right? Okay. Yeah, something like this. On the inner side, you get all these cells like this, the umbrella cells, and the glycose aminoglycan layer is here, right? On the inner aspect, Okay. So what is going to happen? This is a mucus-like layer. It is produced by these umbrella cells itself. And what is going to happen, guys? They stop the direct contact of urine with the urothelium, right? They stop the direct contact of urine with the urothelium. Okay. So, does this glycose aminoglycan layer help pathogens to adhere to the urothelium or not? Obviously not. It is very difficult. As long as the glycose aminoglycan layer is there, it is difficult for pathogens to adhere to the urothelium. Now, in the pathophysiology later, we'll talk about in the disease mechanism, this GAG layer, guys, we see it being destroyed with urinary tract infections. And the moment it is destroyed, pathogens can come and easily adhere, right? Okay, right. Then the next thing, guys, where are we? Here, in the urothelium. So the first thing about the urothelium I want you all to know, let me minimize all of this. So the first thing about the urothelium I want you all to know is the glycose aminoglycan layer, right? Right. Then the next thing, guys, have you all heard this type of proteins called TAM phosphol proteins? TAM phosphol proteins. TAM phosphol proteins. What are these proteins, guys? These are, guys, you all know, guys, in our normal urine, you and I, right? If we have no urine pathology at all, no kidney damage at all, nothing, right? Are we losing albumin? You and I daily with our urine, are we losing albumin? What do you all think? Come on. Are we losing albumin? Answer. Sorry, Shabib? Yes?
No.
No. Not even a little? We do, guys. We lose a little bit of albumin. Actually, guys, in under normal conditions, albumin, we lose a very negligible amount, right? Let me write it somewhere here, right? Normal individuals, you and I, in the urine, we lose usually less than 30 milligrams per day. 30 milligrams per day, we can lose, right? Then there are these other type of proteins, guys, called these TAM phosphol proteins. These TAM phosphol proteins, we can lose a lot more, right? We usually lose about 150 milligram per day can be lost, right? About 150 milligram per day can be lost. Now, look at this. We are losing 150 milligram per day of this TAM phosphol proteins. Isn't that bad for us? What do you all think? It's not, guys. This is one of the most abundant proteins in the urine, and it is a very low molecular weight protein. It's very, very tiny protein. We don't even care about it. Okay. What is the problem if we are losing albumin? What does albumin do in our body, guys? In our circulation, what does albumin do? Come on. Huh?
Maintain colloid pressure.
Maintain colloidal osmotic pressure. Good. Excellent. Right? Because it is a large protein and it helps to keep the fluid within blood vessels. Right? This TAM phosphol proteins, it does no function like that. We don't care even if we lose it, right? So we can lose it, no issue, right? Now, the problem here is, guys, what they have found out was the problem for bacteria, right? These TAM phosphol proteins, there is an advantage for us that it is actually being lost through this urinary tract. What is that advantage, guys? As TAM phosphol proteins are traveling through this urinary tract, from our bladder, through the urethra, and finally outside, right? They have a specific activity, right? Defensive activity against bacterial fimbriae, right? They can specifically attack this bacterial fimbriae, okay, of certain species. Therefore, when the fimbriae is destroyed, can the pathogens adhere to our urothelium? No. Okay, so this is another advantage. Although we are losing this protein, we don't really need this protein in our body, and it is an advantage that we are losing this in the urinary tract. Okay, right? Okay. Then the next one, guys, again about the urothelium. Just write this down in the, once we go to the mechanism, I will teach you all there itself. Here, just write it down, guys, in our urothelium, right? In these urothelium cells, on the top layer, we have these umbrella cells. On these cells, guys, in the urothelium, we have a specific type of receptors called toll-like receptors. Toll-like receptors. We'll talk about this. Toll-like receptor type 4. Right? Just note down now, they have a role to play with neutrophil activation. Neutrophil activation. Neutrophil activation. Just write it down. I will teach you how this is happening. Right? Okay. Right. Then, okay, then we'll come to the next one. Presence of mucosal antibodies. What is this presence of mucosal antibodies, guys? Here, you all know in our mucosa, right? What type of antibodies are present, guys? Now you all know we have IgE, IgA, IgG. What type of antibodies are present in our mucosa? Mucosal areas.
IgA.
Excellent. IgA. Right? Here, guys, IgA is present in our urinary epithelium as well, right? In the mucosal regions. Here, they can activate immune cells and they play a role in complement pathway activation. So that is another defense mechanism that we have. Okay. Right? Then, guys, these commensals. What are commensals, guys? These are organisms that are present, right? And they are working with us. They are not trying to attack us, right? But there are conditions where commensals or this flora can become pathogenic, right? Now, what is the advantage of having commensals within our urinary tract? The commensals or this flora, right? These harmless pathogens, guys. What are the species? First, let's talk about the species, the known ones. Lactobacillus, right? Lactobacillus. Okay. Then we have what we call this Corynebacterium species, right? Corynebacter. What is the disease you all know from this Corynebacter species in children? A very famous one. Don't say UTI, not UTI. Huh? Come on. It's just going out of the topic. Huh? Corynebacterium diphtheriae. Have you heard? Diphtheria. Huh? You all have heard, right? So, okay. Right? That same species, huh? And some species of Streptococcus as well. Some strep species also, right? These are some commensals that are there. Now, what are these commensals doing, guys? They are nicely waiting within our urinary tract. They are not doing any damage to us, no problem, right? They are living side by side with us. What is going to happen, guys? In certain conditions, these species can reduce in number. What are these conditions? One thing, if we put the patient on broad spectrum antibiotics, right? It can reduce the flora. Another thing, certain antibiotic creams can reduce, right? Certain spermicidal gels, guys. Spermicidal gel is, right, you all know, for contraception, right? Usually, when we are advising for contraception, we don't advise to use spermicidal gels alone. Usually, it is an adjunctive agent, right? We usually tell the patient, use the condom plus spermicidal jellies, right? Okay, like that. So the spermicidal jellies also can have some toxic effect on this, on these commensals. So broad spectrum antibiotics, any antibiotic creams, spermicidal jellies, and these bubble baths, guys. Anyone here likes to have bubble baths? Huh? Bubble baths, you all get in a tub and nicely read books and okay, right? So good. Lola, okay? So you have to be careful, okay? You have to be careful. It's okay to have bubble baths, but have to be careful, right? Why, guys? Why is this bubble bath? Now, just the basic. When you all are just having a bath, what is the direction of the water flow? If you are just standing and having a bath, your water flow always comes from the top to bottom, right? It's going to go down. Right. So what is going to happen to any pathogenic? Now you all know, guys, there can be pathogenic organisms. There can be normal bacteria even on your skin. Right. So when you're showering and all, these will also fall down with them. What happens when you're in a tub, guys? What happens when you're in a tub? This is not the case. There is no running of water. There is no, the water is stagnant. Whenever water is stagnant, those organisms, right? Even though, let's say, okay, you have some organisms around your hand, some commensals. Some organisms here, when they go to your urinary tract, they are not going to be friendly anymore, right? They are going to act as pathogens. Okay. So this is the problem. This is the problem with these bubble baths and these, even these bath soaps they have found out to be, there are some bath soaps, right? Heavily, they tend to change the pH of the epithelium of our urogenital tracts, right? So there can be some related problems, right? So what is going to happen because of these guys? The commensals will start reducing, right? Commensals will start reducing. When the commensals reduce, the pathogenic organisms will increase. How? Why does a reduction in commensals or good bacteria cause an increase of pathogenic strains? Why? Always have to ask why. Never memorize. Come on, think and tell me. Yes, it's okay. Dinita, let's go. Why do you think?
There's no competition for resources?
Excellent. Excellent. Competition for resources. This is the reason. So you all know these commensals, guys, in the normal living environment, within our skin and within our body itself, right? They are nicely taking nutrients that we are consuming as well, right? And they are nicely waiting. The moment they drop, there is an excess of nutrition available. So who is going to come and take that nutrition? Pathogenic strains. Excellent. Right? So the competition for nutrients, yes, that is the exact point I wanted to mention. Right? Good. Okay. Right. Then guys, here you all can put a number 7. I haven't actually typed it here. For the males, we have an advantage now, right? This is right. I had during university, guys, I had this study group, right? So this study group, we had two other boys. So with me, 3 boys and 1 girl, right? Genius guys, genius people, right? So what when we were discussing this urinary tract infection chapter, right? The girl was so mad. She's like, we have so many disadvantages, and on top of this, you all have another added advantage. What is this? This is this number 7 point, guys. Our prostate gland, males, right? Prostate, right? Our prostate, guys, actually has a little bit of a protective role. What is this? Prostate, right? With its seminal vesicles and the seminal fluids, it can secrete certain antimicrobial fluids, right? So this is one reason, guys, in benign prostatic hyperplasia. Now, in benign prostatic hyperplasia, what happens? You all know the prostate gland is surrounding the urethra. It's surrounding the urethra. So whenever there is prostatic hyperplasia, the urethra is going to get squeezed. So there is some stasis because of that. At the same time, when there is benign prostatic hyperplasia, guys, right, there is cellular dysfunction. And this secretion of these antimicrobial agents is going to be reduced. That is another reason why these BPH patients are at a high risk for UTIs. Okay. So just write that down. We have from the prostate certain antimicrobial agents that are being released, right? Okay. So these are the basic host defenses that we have, guys. If any of these host defenses are defective, they are not working, that is when the pathogen can cause infection in our body. This is why we said just because there is sexual contact, this is why we are not putting urinary tract infections under STDs, right? Just because you get the pathogen into your urinary stream or your body does not mean you will definitely get a UTI. For you to get a UTI, these host defense mechanisms should be abnormal and non-functioning. Okay, everyone clear up to this point? Give me a thumbs up, right? Okay, right, excellent. So let's move on, guys. There are some other risk factors. Look at these other risk factors. So we've talked about the virulent species. We've talked about the defective host defense mechanism. The other risk factors, right? Now about this female sex, guys, we've already talked about, not shorter, okay? Put a H there, okay? Shorter urethra, right? A bit of a typo there, right? Shorter urethra, shorter distance from the anus to the urethral orifice. We have talked about all of this in the introductory video as well, right? This new sexual activity. What is this new sexual activity, guys? This is the honeymoon cystitis that we mentioned. What is the species? Staphylococcus saprophyticus, right? Then pregnancy, we have already talked about the increase of the progesterone as well as the graviduterus compressing the ureters. We have talked about post-menopausal state, guys. Again, estrogen is going to drop, right? Estrogen is going to drop in the post. You all can write it down, right? Sudden drop in estrogen. What is going to happen, guys? There is the this epithelial lining, guys, of the urothelium, right? When there is a sudden drop in estrogen, what is going to happen, right? We are not going to talk about the exact signaling cascades, but what I want you all to remember is, guys, in the epithelial lining, right? There is going to be a reduced amount of glycogen. When there is reduced glycogen, guys, our lactobacilli, which is our commensals, our lactobacilli absolutely need glycogen for their survival, right? So what they have found out was, when there is reduced estrogen, glycogen drops. When there is reduced glycogen, the lactobacilli can't survive, right? And they start reducing, therefore the susceptibility to UTIs increases. Okay, so this is why you all must have seen these certain companies, right? They are making who are specializing in this post-menopausal milk products, dairy products. They are making special lactobacillus included yogurts and all. They are advertising in this stream. True, they are talking about digestive problems as well, but this is also one of the reasons. Okay. Right. Then, indwelling urinary catheters. What is this indwelling catheter, guys? You all know. Where do we find indwelling catheters? When you all go to the ward. Which patients do you all see? Usually, patients, either they have come for the urinary related procedure itself, or you all know, guys, these patients in palliative care, right? Late stage cancers, right? If they're in palliative care, they're usually with a catheter, usually with a long-term catheter, right? And certain other chronic diseases, right? Or if they're on a treatment, if they're bedbound for a long period of time after some surgical procedure, again, they'll be on a catheter. what is the important thing about intervening catheters, guys? There can be injury to the urothelium from the catheter itself, right? So what is that? Easy access for pathogens. Now, the pathogens that you acquire in the hospital setting, these are what we call from nosocomial infections, right? These ones, guys, usually they are these MDR, what we call multi-drug resistant pathogens, right? So it's a little bit difficult, right? Most of them show resistance to a large variety of antibiotics, right? So it's a bit difficult to manage these cases, right? Right. Then about the obstructive neuropathies, guys, we've already talked about urolithiasis, is this stones, right? Urolithiasis, stones, tumors, masses, right? Benign prostatic hyperplasia, right? Strictures, right? Anatomical defects, right? Whatever, all of these. Now in anatomical defects, guys, in pediatrics, we all will talk about some specific ones, right? One is this posterior urethral valve, right? It happens here, guys, right? Here. There is an abnormality. We'll talk about this. I will describe this in another chapter, right? These are very pediatric heavy chapters, right? I don't want to talk about this today. Just remember there is a defect, right? At the bladder neck area, right? Here we see it as a keyhole sign, right? In, if you do the ultrasound, right? You can see what we call a keyhole sign, or sometimes they call it, in Sri Lanka, you all might have heard the cashew nut sign, right? Same thing, right? We'll talk about that later. Then vesicoureteral reflux. Now, in the introductory class, we took a look at where the ureter is coming and joining the bladder. We talked about how it is coming at an oblique angle, right? So when there is a problem there, an anatomical defect there can be backflow from the bladder to the ureter. This is this vesicoureteral reflux, okay? Right? And then PUJ obstruction is here is pelviureteric junction obstruction, right? Between the pelvis and the ureter at the junction, there is an obstruction, right? This is another pediatric topic, right? We'll talk about all of these. Just know these. If you all know these names for now, it's fine, right? Because these are pediatric heavy topics, right? Okay. So those are some of the anatomical defects. Then, guys, right? Diabetes mellitus. How is diabetes mellitus related with urinary tract infections, right? Look at this, guys. One is this autonomic neuropathy. What is this autonomic neuropathy? You all know in chronic long-standing diabetic patients, right? Their vascular permeability reduces. Blood supply to the nerves is also going to reduce. So there is nerve damage, right? Diabetes, very interesting chapter. I will teach you all one day, right? Right? Here, when there is autonomic neuropathy, there is going to be problems with the micturition reflex. Right? Micturition. What is this micturition reflex, guys? What is the micturition reflex? What do you all think? What do we mean when we say micturition reflex? Is your urination a complete reflex? You have no control of it? What do you all think? You have no control at all? Come on. Unmute, talk. Huh? Guys, if we take the entire process of urination, right? What should you do? First, you should begin the stream, right? You should start urination. You should begin the stream. Then you should maintain the stream, right? You should keep urinating without any stops in the middle, right? And finally, you're going to stop the stream, ending of the stream. These are the three components of micturition, right? This starting and ending of the stream is under your voluntary control, okay? But the maintenance, once you start, right? Once you start urinating, do you have to keep forcing and thinking, okay, urinate? No, it automatically goes. Once you start, it automatically goes. That is the micturition reflex, guys. Okay. So the micturition reflex, right? This is from the sacral plexus also, right? Very important reflex pathway, right? We'll discuss that in another class, right? Very interesting, but a little bit complex, right? If anyone wants a diagram, so there are some diagrams, guys, that I've drawn during my study in university. So these micturition reflex, I've drawn a nice diagram. If anyone wants, just drop me a message after the class, right? I will send it, right? So what is happening here is, guys, during urination, during the stream, it is not under our voluntary control. It's a reflex, right? So when there is autonomic neuropathy, this micturition reflex is going to be abnormal, right? Therefore, there can be stasis, complete emptying of the bladder is going to be reduced, right? Okay. Then, with diabetes, guys, with the hyperglycemia, we can also get immunocompromised. Mainly, guys, we are not going to talk about in depth. Just write down if you all want, right? Neutrophil function, neutrophil phagocytosis function specifically, guys. This is going to be reduced. There are some pathways, right? Cytosolic calcium increases, ATP reduces, right? We don't need to know about all of that. Just know, immunocompromised, there can be neutrophil phagocytosis, reduction, right? And then they can also have inadequate complement pathway. You all know what the complement pathway is, right? Inadequate complement pathway function, again in diabetes, right? Okay, apart from that, guys, this diabetic ketoacidosis, right? Another chapter I taught a couple of years back, right? We'll talk about these later. Here, when there is severe acidosis, right? With diabetes and dehydration, we're going to talk about that later, right? There can be again reduced immune function. Okay, just know that for now, that is more than enough. Immune suppressed individuals, guys, obvious, right? This is what we were talking even in diabetes. But immune suppressed here, we mean patients on long-standing steroids. Now, what is one pediatric condition where you put children on long-standing steroids? A nephrotic, nephrology condition, right? A nephrology condition. Okay, I gave you all the answer, right? Nephrotic syndrome, right? Everyone knows that, right? So they are on long-standing steroids, right? Okay, in nephrotic syndrome, in pediatrics, what is the most steroid-sensitive form? What is the most steroid-sensitive form of nephrotic syndrome in pediatrics?
Minimal change.
Excellent. Minimal change. Okay. Right. Okay. Then, so that is one case. Patients who are on long-term steroid therapy, right? Or any other immunosuppressant medications. Then patients awaiting, that is one. Then the second one is, guys, patients awaiting transplants, right? Right? So before doing a transplant, especially renal transplants, we have to put the patient on immunosuppressants. Otherwise, the moment you give the new kidney, it's going to be destroyed. Okay. Then certain viral infections, HIV, cytomegalovirus, right? You all are familiar with these, right? Then, guys, in pediatrics, there are some conditions we need to talk about. This true phimosis and this labial adhesions. What is this phimosis, guys? Now here, there is a picture here. Phimosis is the inability to pull the foreskin back to expose the glands, right? This is what we call phimosis, right? Then we also have in little girls, we can have this labial adhesions, right? We'll talk about when we come to the management part, how to manage these, but these are quite common. Okay. And guys, another thing we must consider, just put it here, especially in your pediatrics, right? You must consider, right? Just put another one, sexual abuse, right? When you're working as a doctor, you must pay attention to these as well. We'll talk about some signs, right? Okay. Especially when you're taking history from the patient's mother or father, right? If you feel like they're hiding information, right? You have to suspect that there is a possibility of sexual abuse. And then on examination of the genitalia, if there is inflammation, right? You have to suspect these things, right? Okay. We'll talk about how we are going to manage all of these. Right. Is everyone clear up to this point? Right. Then, guys, just for your knowledge, just know, are there any AB blood group students here? AB. Anyone raise your hand? AB blood group? No one? Imesh. Okay. Anyone else? No one else? Okay. Imesh. Okay. You are at a higher risk for UTI. This is, again, guys, this is some research what they have found. Okay. Certain blood groups they have found, right? Again, very, very interesting mechanism, right? Again, this I have a picture drawn, right? If anyone's interested, drop me a message. There are certain genetic components with relation to certain ABO blood groups, right? We call this ABH non-secretor type blood groups, right? Don't worry, right? A little bit advanced stuff. Just remember this AB blood group. This one is known to have a propensity to develop UTIs. Just know that. Right? Someday when you all are doing your doctorates, PhDs, MSCs, you all will remember me. Okay? Hopefully. Right? Okay. Clear? Right? Then let's come to the clinical picture. Guys, is everyone clear up to this point? Now we are going to dive in a little bit more into some heavy content. Right? Is everyone clear up to this point? Give me a thumbs up. Let me see your thumbs going up. Okay, all good. Right. Excellent. Right? Okay, good. Right. So we'll come to the clinical picture, guys. Here, what we are going to do is we are going to look at the underlying mechanism and relate it to the clinical picture, right? What do I mean by that? Firstly, guys, we'll start off with the urothelium itself. Look at this. You all can draw it here itself. Now, what did we say about the urothelium, guys? It is made up of it is a stratified layer. We said the initial basal layer is cuboidal. Then we have a little bit longer cells, right? Some columnar cells, right? Then we have also these umbrella type of cells, right? These umbrella type cells, right? Okay, something like this, right? This is our urothelium. This is just a rough diagram. You all can later draw it beautifully. Now just draw it roughly. What is the What did we say, guys, on this urothelium on the side, right? I will draw it here on the side. We said there is going to be this glycose aminoglycan layer. I'm not going to draw it for the entire urothelium, otherwise it will mess up our diagram. So we have this glycose aminoglycan layer. I will draw it just on this right corner. Okay, right corner. Just keep it drawn like that. That is the glycose aminoglycan, right? Now, what is the special type of receptor we said is present on the cell surface membranes of these umbrella cells? What is the special receptor we mentioned today's class?
Toll-like receptor.
Toll-like receptor type 4, right? These are actually, guys, if you look at the microscopic structure, they actually do look like a T, letter T. So you all can draw some letter T's here. These are the toll-like receptors. Toll-like receptors, type 4, TLR4. What is going to happen, guys? Now let's imagine, let's say, okay, this guy came, a pathogen came, right? A bacterium, some bacteria, right? Okay. And with his fimbriae, guys, he is going to bind to these toll-like receptors. He's using his fimbriae. He will be bound to these toll-like receptors. Okay, toll-like receptors. What is going to happen the moment these toll-like receptors are bound by this bacterial fimbriae? There is an inward, right, signaling cascade, guys. Now we don't need to talk about these, right? Very complex MAP kinase, right? P38, June pathways, right? Very complex pathways, not necessary at all, right? Unless you are going into clinical research. Just know there are some intracellular signaling cascades that are going to happen here, right? We'll look at what is going to result from these intracellular signaling cascades. One important thing, guys, look at this. One very important thing that is going to happen. These intracellular signaling cascades are going to stimulate the urothelial cells to start releasing certain interleukins, specifically, guys, interleukin 8, right? Specifically, interleukin 8. Okay. Now, what is a very important function of interleukin 8? What do you all think? Any function that you all have heard of interleukin 8? There are multiple functions. There's a lot of functions of interleukin 8. But some of them, one major one. Interleukin 8, guys, right, amongst other species, is known to cause activation of neutrophils. Also, talking about today's chapter, just a side point, interleukin 8s also play a major role in pyrexia, in fever onset. This is one of the reasons why in UTI patients we get a thermoregulator set point alteration. Therefore, they present with fever. Okay, that is one of the mechanisms. Anyway, interleukin 8, one of the main functions is they activate neutrophils. Right here, guys, there are different mechanisms. There is one called CXCR1. There's a receptor. Right, not very necessary. Just know that neutrophils are going to get activated. Right, neutrophils are going to get activated. Right. Then let's leave let me mention this CXCR1 also. Look at this, right? A very simple concept, so I will mention it. So let's imagine this as the neutrophil. Now, the neutrophil is going to get activated. Neutrophil is going to open its eyes, right? Neutrophil is going to open. Neutrophil has what kind of a nucleus, guys? You all can remember? It's what we call this trinucleated, right? It has sort of like a three pieces, right? That's the nucleus of a neutrophil. Now, what is going to happen, guys? Neutrophil is going to get activated. Another effect of this intracellular signaling cascade, right, is from these cells, they are going to produce certain other substances, right? We don't need to know the names. These substances come and tell the neutrophil, express these receptors, a special type of receptor. What is this receptor? This is this CXCR1 receptor, right? The neutrophils are made to express these receptors, right? Okay, right? Now, what does this receptor do, guys? The moment these receptors are expressed, right, interleukins come and bind to these. That is how these neutrophils are getting activated by interleukin 8. Okay, right? That is how. Now, I initially mentioned interleukin 8 will directly activate neutrophils. But exactly how is it happening? There is another type of chemical that is going to come and stimulate the expression of these CXCR1 receptors on the neutrophil walls. And the moment interleukin go and binds to these CXCR1 receptors, the neutrophil is going to get activated. Okay, everyone clear up to this? So what is this, guys? It's just imagine it like we are calling the police, right? We are calling the neutrophil to come, and we are giving the gun also. We are giving the gun also to the policeman, right? Right? To tell to shoot the pathogen, right? Exactly what it is. Okay, right? Okay. Then, so this is one thing. These are two things that happen here. Another important thing is, guys, from this intracellular signaling cascades, another thing happens. What is this? Pro-inflammatory cytokine release. Pro-inflammatory cytokine. Now, this is very important. These pro-inflammatory cytokines, guys, they can come and destroy, right? True. When there is pro-inflammatory cytokines, they are going to help what you all have learned in immunology. When cytokines come in, they are going to attract other immune cells to come to this area to help and destroy the pathogen. They will call for macrophages. They will call for lymphocytes, right? B cells to come and produce antibodies. These cytokines will do a majority of the good work. But at the same time, these pro-inflammatory cytokines, they can damage this glycosaminoglycan layer, right? This is a problem. Okay, this is a problem. Why? When the glycosaminoglycan layer is destroyed, what happens? Pathogen adherence increases, right? We'll talk about certain things that happen, right? Right? Okay, so the immune response against the pathogen is good, but the inflammatory damage to our surrounding normal structures, to the surrounding urothelium is bad, right? Right? So this is what causes the clinical features, guys. Clinical features. Now let's take a look at these clinical features, what we mean by them. Let's take a look at Somasiri, right? We have Somasiri here, right? Okay, look at Mr. Somasiri. Okay, nice Somasiri, right? Big smile, nicely waiting. Look at this. Mr. Somasiri, right? Now he's having some inflammatory changes going on within him. Look at this, guys. When there are inflammatory changes going on, right? What is going to happen? One thing, the bladder stretch receptors. Bladder stretch receptors. Now we talked about in our introductory session, right? The bladder has some stretch receptors, right? The bladder stretch receptors are going to be stimulated, right? When it is not necessary. Now, in a normal person, in you and I, when are the bladder stretch receptors stimulated, guys? Usually around what volume of urine? Around in normal individuals? What do you think? Yeah, around 350 to 400, around 350 to 400, usually we get the feeling that, okay, we need to go and urinate. This is why the bladder stretch receptors are sending the signal, right? But what is happening in the case of a UTI, guys? These stretch receptors are going to be hyperfunctional due to the inflammation, right? Therefore, even when the bladder is not full, it doesn't have to be 350, it can be somewhere around even 100, right? Even less than that sometimes, right? The patient gets the need to urinate, right? So the bladder capacity, bladder stretch receptors are hyperstimulated. So the bladder capacity, guys, the capacity, the storage function starts reducing. Because of this, what should the patient do? He should always, what should Somasiri do? Somasiri must always go to the washroom. Always go to the washroom. This is what we call frequency. He must frequently go to the washroom, right? He must frequently go to the washroom. Okay. He wants to go to the toilet, right? Okay. Then let's check next. Now Somasiri gets the feeling that he wants to go to the toilet, so he's walking. He's walking to the toilet. Now, while he's going to the washroom, guys, now usually what happens, you and I, we can walk to the washroom, right? And we can get ready to urinate, right? And then our parasympathetic nervous system will be stimulated. Then that will cause contraction of the detrusor muscle. All of that nice step-by-step process is there in you and I, right? But what is happening in the case of UTIs, guys? When there is infection and inflammation, we said the stretch receptors are hyperresponsive, and right, there is going to be, put number 2, right, hyperstimulation of the parasympathetic nervous system, right? Hyperstimulation due to the infection and inflammation that is going on. So what is going to happen, guys? Now Somasiri is walking to the washroom. While he's walking, what is going to happen? His smooth muscle, detrusor muscle, is going to start contracting even before he reaches the washroom, right? Why? Parasympathetic nervous system hyperstimulation, right? This is when he feels like, okay, now I'm going to pee myself, right? This is what we call, guys, urgency, right? He wants to urgently go, right? This is urgency. So what are you going to see? Patient is going to run to the washroom. Now, initially he was walking to the washroom. Now halfway through, he's going to start running, right? This is urgency, right? Urgency, right? Okay. Then, now what is happening? Okay, finally he ran and finally he reached the washroom. He came to the washroom. What is going to happen, guys? Now he's going to take his pants down. He's going to attempt to urinate. What did we say, guys? When there is infection, inflammation, everything going on, right? The glycosaminoglycan layer is destroyed, right? Remember? When the glycosaminoglycan layer is destroyed, what is going to happen? Urine. Now Somasiri is trying to urinate. Whatever urine that is coming is going to directly contact what? The urothelium. Why? Glycosaminoglycan layer is destroyed. Therefore, what is going to happen, guys? The third thing, due to the GAG being destroyed, the urine is going to come into direct contact with the urothelium and therefore cause a burning sensation. You all know our urine contains high concentration of toxic waste, right? So therefore, there he is going to get this burning sensation, which we call dysuria, pain and burning sensation during urination, right? Okay, so now you all understand why these are happening. I don't want you all to just memorize dysuria frequency, right? Don't just memorize, right? Always understand why. Okay, right? So he's going to get dysuria. He's going to get a burning pain sensation as the urine touches his unprotected urothelium. Now tell me this. If imagine that you're Mr. Somasiri, or Mrs. Somasiri, for the girls. If you're Mr. or Mrs. Somasiri, now you're trying to urinate and there's a burning sensation, right? The moment that very strong burning sensation comes, do you feel like passing urine anymore? The moment that burning sensation comes, no, you immediately want to stop. Therefore, guys, this dysuria is often accompanied by what we call hesitancy or hesitation. Hesitancy, right? Hesitancy or hesitation, right? Often accompanied together, dysuria and hesitancy. Why? Because of this painful voiding, the burning sensation. Okay. So when they are hesitating to urinate, how is it going to look if Somasiri is here and now he's attempting to urinate? You're here, you're the physician, you're observing him urinate. I know it sounds wrong, right? But for the clinical diagnostic purposes, you're observing him urinate. What are you going to see? What are you going to observe, right? You will see his face grimacing in pain and everything. That is true. But what you're going to see is, guys, the patient cannot start the stream, right? Patient cannot start the stream, or difficulty initiating the stream, right? Okay. Difficulty initiating the urinary stream. Okay. This is our main triad, guys, right? Of symptoms. What is this? Dysuria, frequency, and urgency. Okay. Right. These are what we call the cardinal features of urinary tract infections. Okay. Dysuria, frequency, and urgency. Right. Sometimes, guys, have you all heard the term strangury? What is this strangury? Strangury, in some books they mention. What is this strangury, guys? This is dysuria and urgency together. This is what we call strangury. Okay. Just a fancy word. Right. If you all understand dysuria, urgency, and frequency, that is more than enough. Right. Then, guys, so these are the cardinal features. Apart from these, there are some other features that we want to talk about. What are these other features? Right. I will draw this as a man. Right. The rest of the body. Right. This is the umbilicus here, somewhere here. And this is the face here. Right. Okay. This is the face. Right. So apart from these three main symptoms, apart from the cardinal features, what else can be there? Look at this, guys. When there is a urinary tract infection, when there are infective organisms, right, they are doing various metabolic processes within the urinary tract, and they are going to release various chemicals into the urine, the pathogens itself. When that happens, guys, this urine is going to be pungent or smelly, right? Pungent urine. This is another manifestation, pungent urine. Apart from that, guys, here in this area, especially if the bladder is involved, right, there can be suprapubic pain, especially, guys, these pediatric children, they tend to complain a lot when there is UTIs, suprapubic pain, right? Another one here on the top I want you all to write is fever, right? These patients can have fever, right? Okay. And here you can write some patients, guys, they can have hematuria, right? Hematuria. This is in severe cases, guys. Hematuria, not all patients with UTI will get a hematuria, right? Especially, what part of the bladder should be involved for us to get hematuria? What do you all think? Right? This is from the short video. What do you all think? Remember, guys, we talked about a smooth area in the bladder called the trigone, right? If the trigone is affected, there can be hematuria as a presentation, especially in the trigone. Okay. These symptoms, all of these together, right? The primary cardinal features plus these other features that we drew, right? These are what we call, guys, LUTs, lower urinary tract infection symptoms, So these you see in a patient with a lower urinary tract infection, lower UTI. What is our lower UTI? Bladder and below. Okay. Bladder and below. Right. Then, now imagine the infection, the pathogenic organisms came up to the bladder. Now imagine they got into the ureter and they are ascending further up. Towards our kidneys. What is that? Now we are going to upper UTI. So we'll look at the upper UTI as well, right? Let me draw it somewhere here. We'll draw the same man, guys. We'll draw the same Mr. Somapala, right? And we'll turn him around. What do I mean by turn him around, right? I will draw this same, something like this. Same thing, right? But now this is the back of his head. Here. We are turning him around. This is the back of the patient, right? If we look at the back here, right? First, we'll draw some structures, guys. Here in the middle, this is the vertebral column, right? Something like this, right? Vertebral column. And here we have the ribs, right? Ribs going like this. Here you all know, guys, on either side of the vertebral column, we have this group of muscles running down. What are these? Have you all heard this? Right? Bilaterally. Like this, something like this. Right? And then it has a connection here as well. Anyway, no need to be accurate. But what is it? This is the erector spinae, right? Erector spinae muscle groups, right? So if we take a look at this, right? Now we are talking about upper urinary tract infections coming to our kidneys, coming to pyelonephritis. Pyelonephritis, if we take a look at, guys, they can have these same symptoms that we talked about. What are the same symptoms? Dysuria, right? Frequency, urgency. They can have the same stuff, right? Then what did we say? Pungent urine, right? They can have hematuria, and they can also have suprapubic pain. Upper urinary tract infections can have all of these manifestations. But there are some other extra ones. Put them in a different color. One is, guys, look at this. One. Okay. Draw it here. One is the fever, but fever, not like in our lower urinary tract, fever with chills and rigors. High spiking fevers, guys. In pyelonephritis, there are high spiking fevers, right? Fever with chills and rigors, right? Okay. Then, another important feature, guys, they can have, right, pain in these areas. These are what we call the flanks, guys. They can have flank pain, okay? Flank pain, right? Flank pain. Then, again, guys, they can have this other area just on either side of the spine and above the pelvis, right? Somewhere around here, right? Somewhere around here. Here, guys, this area, we call it loin pain, right? Loin pain. This is the area on either side of the spine between the lower ribs and the pelvis, between the lowermost ribs and the pelvis. Let me draw it nicely here, just below the lowermost, okay. Just below the lowermost ribs, huh? We all know our last ribs are what? Our floating ribs, no? Floating ribs. What are the floating ribs and what are the false ribs? Numbers? Come on. Anatomy, first year. Yes, Atif?
Floating ribs from 8, 9, 10.
False?
11, 12.
Yeah, other way around, huh? Good, other way around, right? But good. Floating ribs are 11 and 12. False ribs are 8, 9, 10. Okay, good. No problem. Right, somewhere here it's there, right? Just need to rearrange the synapse a little bit, right? It's okay. No problem, right? Okay. Then, guys, there is another very important manifestation, right? For that, right, there is something what we call the renal angle, guys. What is this renal angle? Let me erase this guy a little bit. The renal angle is, guys, the angle between the last rib and our lateral border of the erector spinae. This angle, right? The angle between the last rib and the lateral border of the erector spinae. This is what we call the renal angle. This renal angle, guys, this area, there is a classic feature called the renal angle tenderness, right? You keep your hand. Now, if this is the patient's, you all can see me, right? If this is the patient's renal angle, you keep one hand here flat and you use the other hand, right, the face, and just give a light tap. Right? Patient will run. Okay. Patient will run and scream. Okay. Right? Very severe pain. Okay. Right? Yeah. When in pediatrics, guys, so I was there with one consultant at uni, right? She was a professor. She actually suggested in pediatric patients, depending on the severity, we don't even want to test the renal angle tenderness sometimes, okay? Because that much of distress to the child, okay? Adults, okay. But children, we don't want to cause that much of pain, right? Okay. So if we are like sure, we don't tend to do it. But I mean, for your exam purposes, you have to mention that you're going to test the renal angle tenderness. You have to say those things. But there are cases where we don't usually need to even elicit that. Okay, right. Is everyone clear up to this point? Give me a thumbs up. Now after coming to my classes, no memorizing, huh? No memorizing, right? Keep this note now, students who have come before, you all know. If you all have my previous note, there will be some, every year, guys, there are updates coming now. So I always keep my stuff updated, right? So even today's session, we always see some updates, right? If you all have come for my previous UTI class, that was held like 3 years ago. The important point I want you all to know, if you understood the concepts, even if you forget by next week, If you understood today, right, next time you just go through your note again, everything will be there. Everything will be there, right? But if you memorize, all other process to again understand. Okay. So when there are some concepts, there are some places where we need to memorize. Whenever there are places to memorize, I will let you all know, right? Some medications we need to know, some emergency protocols we need to memorize. Apart from that, rest of medicine, I 100% advocate for understanding rather than memorizing. Okay. Now, if you all understood this content, let's talk about now today. It's a little bit different, guys. I'm not going to go core concepts first, then clinical skills at the last. We'll go in tandem, right? We'll go together. Now, if you all understood this point, let's come a little bit towards the clinical discussion, right? When the patient comes to you, let's talk about pediatrics, right? Because UTI is a very hot topic in pediatrics. Let's say a mother is bringing the child. Let's say, okay, 9-year-old baby girl coming in with the mother, and the mother is complaining that the mother is complaining of some things, right? I will not tell you that so that I can get it out of you all. Okay, right? Mother is complaining of some things. So obviously, okay, let's say, okay, mother is complaining of fever. Mother is saying, okay, doctor, my child has been having fever for the past 3 days. This can sometimes be your only presenting complaint. Okay, so you have to be tactful enough to go from fever to a diagnosis of UTI, because in pediatrics, guys, there is some condition called pyrexia of unknown origin, right? We get patients, right, who are coming with fever, but we cannot find the cause. It is our duty as physicians to ask as much questions as possible to exclude all possible causes of fever, right? So this UTI comes under this. You have to ask questions from the mother to try and elicit that this is a UTI, right? So obviously, when the mother comes with a complaint of fever, what should we ask? We should ask about the onset of the fever. How many days has it been? How has it progressed? Have you measured the fever at home, right? Have you used a thermometer and measured the fever at home? What was the maximum temperature? All of these questions you must ask about the fever, right? Then you have to ask, has the child had any chills and rigors, especially at night? Has the child been shivering with the fever, right? You must ask these questions, right? Have you given paracetamol? Guys, paracetamol. I'm just curious. So here we have, okay, all of these students, okay, Sri Lankan, everyone's Sri Lankan except for Lula. Yeah, Lula. You're from Saudi Arabia, correct?
Yemen and Ethiopia.
All right. Okay. So for paracetamol, is there a different? What do you all use? Are you all using the same paracetamol or different brand, or what are you all using?
Usually Panadol is like the most common.
Panadol. Okay.
Yeah.
Right. Excellent. I just wanted to clarify that. Okay. Excellent.
Oh.
So you all have the same Panadol. Do you know the dose pediatric guidelines? The doses for giving Panadol to children? Usually under the age of 10 years.
I think once every 8 hours.
Right. Okay. Good. Right. Here, guys, what we are usually our guidelines state, right? 15 milligram per kilogram of body weight, right? Especially under the age of 6, we must give it for body weight, right? After 6, there are some, it depends, guys. The guidelines usually changes from hospital to hospital, sometimes from practitioner to practitioner, right? They like to change this a little here and there. But we generally, right, under the age of 6, we must go. Under the age of 10 also, we prefer to go with this 15 milligram per kilogram. 15 milligram per kilogram. Okay. We give it according to the weight, right? Then, once we come to the adult ages, that's when we give according to the hours. We just take 2 tablets like that. Okay. Now 6 hours, 2 tablets, 8 hours, 2 tablets like that. Right. Okay. So this paracetamol, you have to ask about the dose, right? Ask about the dose. Then, guys, now look at this. Tell me, unmute and talk. How will the mother complain to you as the physician that the child is having dysuria frequency or urgency? Now we are talking about a, let's say 6-year-old girl. How is this child going to come with dysuria frequency and urgency? What will the mother tell you all? Come on. I want you all to get this thinking pattern, right? Answer. Let's talk about dysuria. How will the mother... Abdominal pain. Okay, 6-year-old, they can talk a little bit more. Okay, let's say 1.5-year-old child, 1.5-year-old baby. How will the mother present to you regarding dysuria? Come on, unmute up. Sorry?
Crying when urinating.
Excellent. Crying during urination. Okay. Frequency. How are you going to ask the mother about frequency? How are you as a physician going to ask the mother? Let's say 6-year-old child. How are you going to ask the mother about frequency? Come on. Does the child frequently go to the washroom, right? Here, guys, yes, you can ask that. But what we prefer to ask is especially during the night time, guys. Nocturnal, right? At night times, does the child wake up at night to urinate, right? That is the key feature. right? Does the child wake up at night to urinate? And if so, how many times? How many times, right? This is how we ask. Then about urgency, how do we ask? Again, now, especially if it's a bigger child, you can ask, does the child run to the washroom? Otherwise, if it's a tiny baby, we cannot usually ask about urgency, guys, right? Not practical, no? Right? So these kind of things are there, right? Then about pyelonephritis, what should we ask? High-grade fever, chills and dry gauze, flank pain, right? Especially if it's a bigger child, they might complain, right? That the bacteria is hurting, right? They might complain, flank pain, and they can have any of the lower urinary tract symptoms. Always remember that, okay? Right. Then guys, one other important thing now, you have to ask about what happened in the current episode after coming to the hospital, was treatment started. You have to ask about all of that, right? You all are already familiar with that part. One important point you must not miss when you're taking the history from the mother, is this the first episode? Is this the first episode? If not, if this is a recurrent episode of UTI, you must ask everything about the past episode. You must ask, when was the first one? Was a culture done? Urine culture done? What medications were given that time, right? After the medication stopped, when was the next attack, or when was the next episode? Is today the second one or the third one? What, right? Like that you have to ask, because recurrence. If it is a recurring form of UTI, what did we say? It's a complicated UTI. If it is a complicated UTI, our management is different. So you must ask all of these questions. Okay, right? Clear. And you can ask about any scans. As in pediatrics, you already talk about, guys. There are MCUG, right? I'll not mention those, right? We'll talk about those in a different class, right? Right. Then another important point here, guys, what I want to mention, these atypical presentation, there can be, just I want you all to know, as physicians, you all cannot miss cases of UTI. UTI is a very simple disorder. If properly treated, won't progress to lower urinary tract. If properly treated, no issue. But if you do not catch it and treat it properly, it can progress to pyelonephritis. Pyelonephritis is a medical emergency, right? So you should not miss a UTI. Therefore, you have to know there can be these atypical presentations, guys. Sometimes there can be patients coming in with these absent cardinal features. They are only coming with a low-grade fever. Cardinal features are absent, right? No suprabupic pain, no loin pain. So you have to take note of this. You all might have to do some additional investigations, some additional scans, right? The cultures might need to be done, right? Whatever it is, just know that there can be some atypical presentations. The next thing, guys, UTI associated with altered mental status, very, very, very important, right? In geriatric care, very important. In elderly individuals, right? What is this? What do I want to tell you all? Especially patients over the age of 60. Right? If they are coming with altered mental status, what do I mean by that? Child is bringing the dad. Dad is, let's say, 67 years old, right? Coming in, doctor, since today morning, my dad is behaving abnormally, right? I don't know what is wrong with him, right? And he doesn't know where he is. He seems confused, right? That is the complaint. If that is the case, right? Your first thing is to exclude a UTI, right? Exclude a UTI. Why, guys? This altered mental status, right, can be happening in this elderly population due to UTIs, right? Now, what do I want to mention here? Obviously, guys, if the 67-year-old father comes with the child and the child is saying, doctor, today morning, he hit his head on a wall or something. And since then, he's having problems in thinking and consciousness and issues, then obviously you don't need to exclude a UTI, right? If there is obvious traumatic cause, no need to exclude UTI. But if there is no obvious cause and the patient is elderly, above the age of 60, presenting with altered mental status, you must exclude a UTI. Okay, must exclude a UTI, right? How does this happen, guys? We also don't know exactly why, but what they're saying is these inflammatory mediators, right, various biochemical agents, they can cross the blood-brain barrier and go and affect cerebral functions. Okay, right? So one of the first things you must exclude. Okay, right. Then we will come to this presentation. The next presentation is recurrence. Here, guys, we are talking about the chronic forms of urinary tract infections. Here, there are several things I want you all to know. Look at this. I've drawn this here, the 3 lines for you all, right? You all can put the vertical lines as well. Draw 5 vertical lines on that case. Draw 5 vertical lines, right? And the 3 lines, we will name them A, right? A, B, and C. These are 3 patients. Patient A, patient B, patient C. Right? Look at this, guys. The first line. What is this first line? Right? The patient is arrives at the hospital. Right? Seeking care, seeking treatment. Right? The second line is you start what we call empirical therapy. I will explain what empirical therapy is. You start treatment. This is the second line. right? Right. Then, so there is an antibiotic course going, right? You can put this antibiotic course, right? Don't worry, we'll talk about the drugs and everything. Then you stop the treatment. This third line is stop the treatment. Stop the treatment, right? The fourth line here is 7 days after stopping treatment. 7 days after stopping treatment, right? And this last line here is 14 days. 14 days after stopping treatment, right? 14 days after stopping treatment, right? Okay, understood. What am I trying to show here? Look at this, guys. We'll look at one by one. Patient A comes in, right? Sorry. Patient A comes in, right? Patient A comes in. He arrives at the hospital, right? You do the necessary investigations. We'll talk about what all of those are, right? Let's say you do a culture. You do a culture in this patient. When you do a culture, guys, right? Let's say you are seeing this green color organism. Let me put it here. Green, right? Green is what? Culture positive for organism, let's say organism X. Organism X. Culture positive for organism X. Okay. Right? Then let's say now you started the patient's antibiotic course, right? You started the antibiotic course, right? During the antibiotic course also, guys, you can test the patient's urine. During the antibiotic course, you can test the patient's urine. When you're testing the patient's urine during the antibiotic course, you see this. What is this red, guys? What I want you all to put here, right? Put red here and write this is negative. Negative for organism X. Negative for culture, negative for organism X. Culture negative for organism X. Okay. So what does this show? The treatment was good. The treatment was good, right? Culture, when you did the culture initially, organism X was there. Then you started the antibiotic treatment and the organism X is now no longer there. It's negative. It's negative. So you stop the treatment. You stop the treatment. Here, guys, 7 days after, right? Within 1 week, within this first week, within the first week, you tell the patient, right? Just before the 7th day, come for another culture, right? So within the first week, you tell the patient, come for another culture. Within the first week, when the patient comes for another culture, what are we going to see? We are seeing this green again, right? What is this? Positive for that same organism X. What do we call this scenario, guys? This A is called a relapse. This is called a relapse. How do we define a relapse? Positive for the same organism on culture, right? Within 1 week of stopping the medication. This is the definition of relapse. This is the definition of relapse. Okay. Everyone clear? Everyone clear about relapse? Right? Okay. Then we will go to scenario B. Again, let's say scenario B, the patient came in, right? The same green fellow, right? Organism X is there. Organism X is there. Then you start the medication. What are you going to see? You're going to see it red, right? Negative for organism X. Then within the first week, when you tell the patient to come back to the hospital, you check again. Within the first 7 days also, it's negative for organism X. Within the next 7 days also, it's negative for organism X. Okay. Then after that, after a while, maybe 1 month later or something, right? The patient comes again. You don't even ask the patient to come now. After these 2 weeks, no need to tell the patient to come again for another follow-up, right? Is it UTI? After about a month, the patient comes again and he's complaining, doctor, I have the same symptoms again, right? And this time you do another culture and you're going to see this yellow guy, yellow color guy. What is this yellow color guy, guys? This is a positive culture, positive for an organism. Let's say this time Y, a different organism, or Z, Y, okay? This is a different organism. What is this? This is what we call a reinfection, guys. Reinfection is, how we define it is, right? The patient getting an infection from a different species, right? After 2 weeks of treatment completed for one organism. Okay. This is a reinfection. Okay. Understood? Right? Then guys, look at this. The third scenario, right? The third scenario, guys, is going to, I'll name it. You all tell me how to draw it, right? Treatment failure. How will you draw the treatment failure here? How will you draw the treatment failure here? Huh? Come on. Tell me, I will draw. Huh? Tell me what to draw, I will draw. Treatment failure. Let's say organism X. Treatment failure, organism X. How should I draw it? Come on. Unmute. Image. How should I draw it?
Whole B.
Excellent, excellent. Unmute and talk, guys. Right? Okay, don't be shy. Right? All green. Right? This is what we call treatment failure, guys. This is what we call treatment failure. Is everyone crystal clear about relapse, reinfection, and treatment failure? Right? Don't mix these three up. Okay? Don't mix these three up. Okay? Right? All good. All good. Give me a thumbs up. Right? Okay. Right. Then we'll go a little bit more in depth into the clinical part. Right? Look at this, guys. We'll start off with the diagnostic investigations. Right? What are we looking for? First thing I want you all to know, even before going into this, when do we do diagnostic investigations in a patient with a UTI? That's the first question to answer. When are we going to do a diagnostic investigation? Here, guys, what I want you all to understand, right? When a patient comes complaining of UTI manifestations, patient is coming complaining of this dysuria frequency, right? Urgency, all of these, right? High grade fever, low grade fever, whatever. First thing, what do we want to do, guys? We want to know if it is an upper UTI based on the symptoms. We are going to build up a picture to see if it's upper UTI or lower UTI. Lower UTI, right? Upper UTI or lower UTI. If it is upper, what is it? It is an emergency, right? We'll talk about that later, right? We'll talk about the diagnostics, investigations. We'll talk about all of that. If it is a lower, what is our next question? What is our next question to answer? Is this complicated or not? Right? This is our next question. Here, guys, if the UTI is complicated, now we talked about the definition of complicated and the definitions of uncomplicated. Based on those, right, by definition, uncomplicated means what? Right? Non-pregnant, all the non-stuff. Non-pregnant female, not recurrent in nature, and no other associated diseases. What I did was this, even in my university period, I just remembered the uncomplicated. Everything else falls under complicated. Okay? Right? So, here, if it is uncomplicated, we usually do not need to do, usually not, right, need to do diagnostic investigations, right? We can start directly with the treatment, right? What we call empirical therapy. We'll take a look at that. If it is a complicated one, guys, we must do diagnostic investigations. Okay? All complicated cases, we must do diagnostic investigations, right? We are starting therapy even before the culture results and everything comes. We are starting empirical therapy in complicated cases as well. However, we must send the samples for further examination. That's what I mean. Okay. Right? Okay. Now, what are we going to do, guys? One of the first investigations that we want to do in a case of UTI is the urine full report. What is the urine full report, guys? What is a urine full report? What is the difference between a urine full report and okay, what are the components in a urine full report? What do we have? Come on. Everyone's fourth, fifth here, except for one. Yeah, what is it? Atif, go.
Urine for protein.
Okay.
Red blood cells.
Okay.
Cast.
Okay. Anything else? Good. Anything else?
pH.
Okay, good. Excellent. What else? Some sugars. We want to look at some sugar as well. Right? Sugar. Okay. What else? Nitrates, nitrites, right? We'll talk about those, right? Some esterases, right? Good. You remember. Okay, look at this. Here, guys, when we are taking the urine, we are taking it one for the UFR and one for the culture, right? The UFR, there are mainly two things that we are looking for. One, we are going to do the dipstick investigations, right? And the other one is the cytology. Cytology is under the microscope, light microscope. Okay. This is our basic urine investigation, a UFR and a culture. Under the UFR, we are doing the dipstick. And just give me a second. Guys, can you all hear me? All good? Yeah. Sorry about that. Can you all hear me? Yeah. Okay. Let me share the screen again. Problems, guys. Problems. One second. Right. Can you all see the screen? All good? Yeah? Right. Okay. Excellent. Give me a second. Yeah, there we go. Right. Okay, I can see you. Right. So in the urine, what are we going to do? A UFR and a culture. UFR and a culture. In the UFR, we are going to do the dipstick and the cytology. Now here, go to your skeletal notes, guys. I have put a picture of a box. Right. This is from a box of a dipstick kit. All of these things we are going to look for. Leukocyte esterases, nitrates, right? We're going to look for nitrite, right? We'll talk about how that is working. Urobilinogen we can look for. Proteins we can look for. pH, right? Ketones, right? Blood sugar, right? Bilirubin, right? All of these we can look for. All of these things in one single dipstick. This is one dipstick, guys. This is one dipstick. It will show all of these. Usually we keep it dipped in the urine for about 60 seconds, sometimes 2 minutes, depending on what exactly we are looking for. But usually within 1 to 2 minutes, we can check. All of these will be shown in one dipstick. Okay, right? Okay. Now look at this. So before we do this urine investigation, what should we first do? First, we should collect the sample. Collect the sample. How are we going to collect the sample, guys? For this, right, there are some advices we need to give the patient. The first thing is wash the hands, right, and clean the genital region, right? Wash the hands and clean the genital region. Now, if this is the parent and the child coming in, right, you must get the parent to clean the child's genital region with soap and water, soap and running water, right? If it is a male child, guys, when we are doing the sample collection, if he has not been circumcised, the foreskin must be retracted, okay? And if female, right, the labia must be separated. Also, not just in children, guys, the labia must be separated also in adults, specifically in obese adult females, right? In obese adult females also, labia must be separated, okay? Right? Then, urine from the initial portion of the stream must not be collected. The first 2 to 3 seconds of urine, guys, we are not going to collect it. Why? We talked about in the anatomy session, in that short video, we said the distal portions of the urethra can harbor some organisms. So we do not want those organisms getting into the sample, right? Right? The distal portion we don't care about, right? Those organisms are anyway there, so we don't want to look at them. We want the organisms who have colonized inside, right? More inside, the proximal areas of the urinary tract, right? So the initial portion we are going to discard. First 2 to 3 seconds we are going to discard, right? Usually, guys, you all will see in some guidelines, they say we prefer the early morning voided sample. Early morning as the child wakes up, the first urinary sample is the one we like to take, right? Then there is this midstream clean catch. What is this? Look at this, guys. Let's say this red I'm drawing here, the orifice of the urethra. And here somewhere I will draw the commode or the potty or whatever, right? Right? Now what is happening? Urine is going to come this way, no? What do we mean by this midstream clean catch? One thing is, guys, midstream, the collection cup, we are going to use a sterile collection cup, a small plastic cup. This collection cup must be placed in the middle of the stream. In the middle of the stream. This is what we mean by midstream. Why do we want to place it in the middle of the stream? Why not go towards the urethra very close? Or why not go towards the commode or the wash basin, wherever they're urinating to, the end point, and collect it? For obvious reasons, guys. If we are going more towards the commode or the end point, right, there can be splash, there can be other substances falling into it. The distance is too much. If we are collecting just at the urethra somewhere here, what can happen? We can accidentally knock the plastic container on the skin and on the mucosal areas. Then those pathogens will fall into even dead skin cells can fall into the sample. So we don't want either of those. We are taking the middle grounds, right? Midstream. Then what is this clean catch, guys? What is this clean catch? What do you all know about clean catch? What do you all think? Come on, just try to come up with something. If you all, what is clean catch? Come on, answer. Dinitha, what is clean catch? Okay, it's okay. Manari, clean catch.
Put urine directly to the cup.
Sorry, I cannot hear you.
Put urine directly to the cup.
Excellent. Directly to the cup. What do you mean by directly to the cup? We don't want the urine coming down the leg or something that you are going to collect, right? Okay, the child's thigh, the urine coming to the thigh, and then you're collecting the sample from that urine that is flowing down along the thigh. No, that is not what we are going to collect. Directly from the urethra to the cup. Okay, it cannot touch any other body surface before it comes to the cup. Okay, this is what we call a clean catch. Now, this is as you all can imagine, this is a little bit difficult in obese patients, especially obese females, right? So, certain conditions, if they are morbidly obese, right, they might need help of a chaperone as well. Okay, right, to collect the sample. Right. So, midstream clean catch into a sterile plastic cup. Sterile plastic cup. Don't forget these words, guys. We must tell these words, even in exams when they ask, this is how you have to explain. right? Okay, then the next thing, bottle cap. These are obvious things, so guys. Bottle cap should be immediately closed, right, and quickly transported to a nurse, okay, to a nurse's station, right, and from there to the lab. Important point here: you must label the bottle. They are based on different laboratories. They will have a labeling sticker, right? The patient's name, age, or the patient's registration number, or something like that is there. Whatever it is, label it. Don't send without labeling, right? Patient without a UTI is going to get diagnosed. Okay, right? Then, the next thing, right? Look at this, guys. Just some extra points for in pediatrics. Let's say you have a 1.5-year-old child. Now you want to collect the urinary sample, right? What can you do? You tell baby, come on, please pee. Huh? Fellow is not peeing. What are you going to do? What can you do as the physician? What can you do? Let's say, okay, 6-month-old child or 5-month-old child. Maybe he's not peeing. What can you do to collect the sample? Hit the fellow.
Ask the mother to breastfeed.
Excellent. If the child is being breastfed, ask the mother to breastfeed. Right? The moment you breastfeed, after about 5 minutes, the child will start to urinate. Okay? Child will start to urinate. Okay. Let's say, he's a little bit of a bigger child, right? But still not urinating. You tried feeding some liquids also, not urinating. What can you do next? What is another thing you can do? Huh? Any idea? Sorry?
Wait and watch.
Wait and watch. Wait. Okay, Shabi. Wait and watch. Yeah, you can. But we are risking pyelonephritis. No need to risk that. No, right? Right. Good answer. I like it. Okay. Look at this. Not wait and watch. Don't wait and watch. What we are going to do is we can use a catheter, guys. We can pass a catheter into the urethra, right? Send it a little bit in and draw it back out. Send the catheter a little bit in and draw it back out. In and out. When you do this, guys, right? Due to the urethral stimulation itself, these babies, right, not very tiny babies, right, 3-4-year-old children, they will urinate. Okay. So you can pass a catheter in and pull it back out. You don't need to send the catheter all the way up to the bladder. Huh? That's not what I'm talking about here. Just pass the catheter slightly in and pull it back out. The child will urinate. Okay. Right. Then another thing. Let's say this is a already hospitalized. Let's talk about adults. Already hospitalized adult patient, right? And let's say he's on a catheter. How are we going to take the urine? Are we going to take the catheter sample? From the catheter, are we going to draw urine out and take it? What do you all think? Guys, sorry about that. Can you all hear me? Give me a second. Give me a second, guys. This is what to do. The router keeps turning off. Electricity to the router is going. Electricity to the lights are there, right? You all know this half a phase goes. Problems, guys. Problems. What to do? Give me a second. Very sorry. Apologies. Guys, can you all see the screen? Yeah? No, not yet. No? Yeah, okay. Right, good. Give me a second. Let me see your faces. There we go. Right, okay. So where are we? If it's an adult, if he's already hospitalized and on a catheter, guys, we will take the catheter specimen. It is good, right? The catheter sample is good, right? Take the catheter sample, right? If there is, let's say there's a patient in the hospital, right? He's not catheterized, adult male patient, I will say, with a severe benign prostatic hyperplasia, or even you can say any severe obstructive cause. Any severe obstructive cause can be prostate cancer, right? Can be a severe spinal cord injury that has caused a complete obstruction, right? Whatever. Severe obstructive cause, male patient in the ward, not catheterized. How can you take the urine sample? Can you ask him to urinate now? You can't ask him to urinate because urine is not going to go. Severe obstruction, right? What are you going to do? There is something called suprapubic aspiration, right? So we are going to pass a small tube, right? From the outside, right? This is from the outside, in the pubic region, right? We are going to go in all the way to the bladder and draw out the stored urine. Okay, this is suprapubic aspiration. Okay, so these are some extra things. Then, guys, we talk about this urine dipstick. Now we looked at that box. There are multiple things we see in the urine dipstick, but the important two, one is nitrite test and the other one is this leukocyte esterase test, right? These are the two most important ones, right? What is this nitrite test? Look at this, guys. Specifically, there are some organisms, some pathology organisms like E. coli. These guys can convert nitrate to nitrite, right? They can reduce nitrates to nitrites, right? They have the ability to do this. So if your urinary tract is full of this E. coli species, when you test the urine for test the urine for nitrites, you are going to see an increase in nitrites in the dipstick. Okay. So they can convert endogenous nitrates into nitrites, right? Right. How do I remember this, guys? Bacteria ate the nitrate. This is how I remember it. Bacteria ate the nitrate. Okay. Okay. So what do? They eat the nitrate and release nitrite. The nitrite is the one that you're going to see on the dipstick. Okay. Right. So that is one method, especially E. coli. Yeah. E. coli. Very famous. Then the next thing, leukocyte esterase test. What is this leukocyte esterase test, guys? You all know, right? Our WBCs, right? When they are attracted to some site of infection, they come to that area. They do multiple functions depending on the type of WBC. But one of the things they do is they degranulate, what we call degranulate, to release various interleukins, various cytokines, right? Whatever is needed to get rid of the infection, right? So these degranulated substances, guys, one such substance is this esterase enzyme. Esterase enzyme. This is by WBC degranulation. Now, what is going to happen, guys, if there is, you do the dipstick and you see a positive leukocyte esterase enzyme? That means what? There has been a large amount of WBCs that have arrived at the urinary tract and are releasing a large amount of esterase enzymes. That means your urinary tract is being colonized by a large amount of bacteria. Okay, clear? So a positive esterase enzyme is an indirect indicator that there are bacteria colonizing the urinary tract. Okay, so these two tests are the most important in urinary dipstick. Nitrite test, leukocyte esterase. Okay, do not forget. Then apart from that, the pH we can look for, right? We talked about the pH, how it's a host defense mechanism also. In the dipstick itself, you can look for the pH, right? Specifically, this just extra points for you all. I'm mentioning these. Usually won't come in exams, but for you all to understand. This pH, why did I put this more than 9? Right? There are some species of bacteria, what we call urea splitting organisms, right? Urea splitting organisms. So what can they do? They can split the urea, hydrolysis, right? Via hydrolysis, they split the urea and they release ammonia. Once ammonia increases in urine, the pH increases a lot. It becomes very basic, right? So one primary example is, guys, Staphylococcus saprophyticus, right? This is where in our honeymoon cystitis, right? We see they have the ability for urea splitting. Okay. Then, guys, cytology, yes, like Atif said, right? We can look for pus cells, red cells, bacteria, right? Usually, guys, pus cells, we say 5 to 10, depends on the age of the patient and the laboratory guidelines available. There are some guidelines, guys, where they say more than 5, some guidelines say more than 10. Right? So follow whichever guideline your country is following at that time. And for pediatrics and medicine, it can be different. Right? Sri Lanka in pediatrics, we usually say 10. Right? Okay. Pus cells greater than or equals to 5 to 10. And plus or minus WBC CAS. Red cells, usually if it is more than 3, some guidelines say 5. Right? They say, and bacteria, guys, usually we say more than 15 per high power field. More than 15 bacteria you see per high power field. Right? Here, guys, when pus cells are there in urine, what do we call it? Pyuria. When RBCs are there in urine, what do we call it? Hematuria. Right? Okay. Here, guys, just one, under the cytology, just write down somewhere, there is one condition, right? Where, right, the patient is having symptoms of urinary tract infections. Right? Specifically, he is having symptoms of lower urinary tract infections, this dysuria, frequency, urgency, these kind of symptoms. However, when you do the cytology, you do not see a single pus cell, you do not see a single red cell, you do not see a single bacterium. If this is the case, guys, this is a special case, right? We call this, write it down somewhere, urethral syndrome. If we are suspecting urethral syndrome in a patient, guys, we must look for other etiologies other than infection. We have to look for anatomical defects, right? We have to look for other comorbidities, diabetes, whatever, right? That can cause these manifestations without any pathogen. This is called urethral syndrome. Okay. Right. Then coming to the culture. Now for the culture and even for the UFR, how are we collecting? Midstream clean catch. When we culture it, guys, what are we going to do? You all know, right? We put it in a agar, or there is a McConkey medium, right? Agar medium, sheep blood medium, right? Various mediums are there. We put this sample in this. You all know you all have to inoculate this way, then turn it 90 degrees again, then inoculate this way, right? You all have done this in your laboratories, I think, right? Second year, I think, right? Okay. Inoculation, right? So this is what we do here. We take from the midstream clean catch and we inoculate it and keep for a amount of period for that specific organism and the specific culture medium, and we look at the result. Here, guys, we are going to look at the colony counts. Now, this culture is the gold standard. It is the gold standard for diagnosis. Here, guys, right? If we are looking at the midstream clean catch colony count, right? We are going to look at what we call colony forming units, CFU. If the colony forming units are more than or equal to 10 to the power 5, that means what? 100,000, right? 100,000. That's 10 to, yeah, it's 5 zeros, right? 10 to the power 5, right? If it is more than 10 to the power 5 per milliliter in an asymptomatic patient, right? Now, what we will talk about what this asymptomatic patient means. Okay. We'll talk about when we come to the final discussion. That is significant. In a symptomatic patient coming with all the classic features, right? And if the patient is a female or a child, again, 10 to the power 5, more than 10 to the power 5 colony forming units is diagnostic of a UTI. In adult males, guys, we are lowering the bar a little, more than 10 to the power 3, we say. Why are we lowering the bar in adult males? Now, we have talked about the physiology. We have talked about the differences in the reproductive systems. Why? Why should we lower the bar a little bit? For males, adult males, for us. Huh? Come on. Think. Come up with some hypothesis. Right? I want you all to get this thinking into your head. Right? I don't want you all to give me one. It's not common in males. Okay. It's not common in males. Okay. So when it is not common in males, what is your thinking? What is going on in your head? Why this patient might be having a UTI, or why should we lower the bar? Why is it 10 to the power 3 enough? Why not go for 10 to the power 5 also in males, adult males? What do you think? Now, like Manari said, Satami said, right? True. It is not common in males. If it is not common in males, if UTIs are not common in males, right? Because we talked about the host defense mechanisms, we talked about the advantages of the prostate, we talked about the difference in length of the urethra, right? If that is the case, if infection is unlikely in a male, what should we suspect? There is some other underlying problem going on in the male to cause the UTI, right? Okay, to cause the UTI. Maybe an anatomical defect, right? Maybe another chronic disease related problem, right? Whatever. There is some other problem underlying to cause this UTI in an adult male. Because of that, we do not want to miss diagnosing that underlying problem. Okay. Therefore, we lower the bar to 10 to the power 3, even 10 to the power 3, that is 1,000 colony forming units is still significant in an adult male. Okay. Now tell me this. What is a colony forming unit? I should have mentioned that at the start. What is the difference? Look at this case. Colony forming unit and colony. Is it the same? Huh? No, this is why I don't want you all to memorize these things. Huh? Colony forming unit versus colony. What's the difference? Very basic questions. Huh? You all have to be able to answer these. Look at this, guys. The first thing I want you all to know, they are not equal. A colony is when you take the Petri dish. When you take the Petri dish to your hand, right? Either microscopically or sometimes even physically, you can see colonies like this, right? Different colonies they have formed. These are colonies. These are large. What is a colony forming unit is, guys, within these colonies, you look under the microscope, within these colonies, how many viable organisms are present, right? This is what we are calculating with colony forming unit. There is actually an equation there, guys, right? Number of colonies into what we call the dilutional factor, right? No need to know today, right? We'll talk, this is not necessary. But what I want you all to understand is colony forming unit is not equal to colony, okay? Don't mix the two up. You all can't just take a Petri dish, look at the number of colonies and say there are only 5. So this is not 10 to the power 5. So this patient is not having a UTI. Okay. That is different. Okay. Colony forming units, we are looking at the number of viable organisms within colonies. And there's a mathematical equation there, right? Something called the dilutional factor. We are going to multiply and find the number. Okay. Right. Then the next thing I want you all to know, if now we said in some patients, right, if there is absolute obstruction, severe obstruction, we can do something called a suprapubic aspiration. if we can do the suprapubic aspiration, any growth is significant. We don't need to look for 10 to the power 3, 10 to the power 2. We don't care. Even if 1 is there, it is significant. Why? Why? Tell me why. Unmuted talk. Why? Huh?
It is sterile.
It is sterile. Suprapubic aspiration, we are directly taking the sample from the bladder. Therefore, the organisms, any organism that is there are directly those present in the bladder itself, right? So it is 100% confirmation. Even if 1 is there, it is a significant group, right? Coliforming units, right? Okay, right. Then, so we've talked about all of these things. Next thing is, guys, some special investigations, right? Here, what I want you all to know, there are some imaging things we can do in patients, guys, but we do not do imaging for all patients. That's the first important point, right? There are some relative indications, right? Not absolute also, relative indications that we want to suggest that the patient go and do an imaging study. What are these indications? Write down. First one, patient with a treatment failure. Now, what is treatment failure? We have talked about, right? Patient with treatment failure, right? The other one, patient with unusually severe symptoms. That's the second one, right? Okay. And the next one is, guys, any adult male with a UTI. Now, all of the males here, you are adults now, right? If you all get a UTI, you must do imaging, right? You must do imaging. Why? The same reason we said before. If an adult male gets a UTI, it is likely some other underlying cause going on, some anatomical defect, something. We need to look for that. Right? Right. So what are the imaging choices, guys? One is ultrasound scan KUB, kidney, ureter, bladder protocol, right? Ultrasound scan KUB. Senior students here, 4th, 5th years, how do we send the patient to get an ultrasound scan KUB? What is the requirement? How do we send the patient to get the scan done?
Full bladder.
Send the patient with a full bladder. Excellent. Send the patient with a full bladder. Right? Good. So what are we looking? We are looking for calculi, any obstructions, anatomical defects, all of these we can see, right? Okay. Then CECT or MRI, guys, there is a place, but not commonly done, right? Again, yeah, not very important. Ultrasound KUB, very important, right? If the ultrasound does not yield satisfactory results, right, and you cannot find the proper underlying cause, then you can go for a contrast enhanced CT or a MRI, right? Then, guys, the next thing I want you all to know, right? Blood investigations. Yes, we do this for all the patients that are coming in with urinary tract symptoms. Whole blood count. We can check the CRP, right? Blood picture we can check, right? One important thing, guys, I want you all to write down here, right? Put D, right? We can sometimes, in some patients, we do a blood culture. When do we do this blood culture? Especially in pediatrics, right? Sometimes we do a blood culture. Here, guys, what I want you all to know, this we do it if there is an abscess. What is this? We call it a perinephric abscess. What is this perinephric abscess, guys? There is an abscess somewhere around the kidney. Okay, right? Look at this. How is this happening? This is, guys, if I draw the kidney, something like this, right? Something like this. Now, this is usually with pyelonephritis, upper urinary tract infections. With pyelonephritis, guys, what can happen? The organism arrives at the kidney, right? Now here kidney, and here we have the adrenals somewhere there, right? Okay. When the organism arrives at the kidney, guys, once it has completely colonized all areas of the kidney, now it will start moving outwards. Right? Okay. Towards the renal capsule and outside. It can start even going outside. Once it goes outside, guys, if you all have done human anatomy dissection in your first year, right? If you all have taken a look at the kidney, right? In the actual dissection, not pictures. If you all have taken a look at the kidney during dissection, you all might have seen there is fat surrounding this kidney, right? There is fat surrounding the kidney, right? We call this perirenal fat. Now what happens, guys, as these microorganisms start migrating towards this outer capsule, outer covering, and they come out of the kidney as well, they reach the perinephric fat and they like to eat up this fat. So there is going to be perirenal fat necrosis. You all know whenever in our body there's a necrosis going on, what happens? Our WBCs come, especially our macrophages come, right? Our fibroblasts, they like to come, right? CD4 plus T cells, they like to come. What is going to happen, guys? They come to this area, they envelope all this necrotic material, right? And they form an abscess, right? They will keep the necrotic center in the middle, right? with a nice fibrotic outer covering. This is what we call an abscess. So this occurs somewhere around the kidneys. That's why we call it a perinephric abscess. These are actually quite large, guys. Perinephric abscesses are quite large. Quite large. How will you diagnose, how will you suspect a perinephric abscess in a child? Pediatric patient. Okay, firstly, any abscess anywhere in the body in any patient. What is one of the major clinical features? Come on.
Hills and ricos.
I heard two answers. Sorry, I heard both from both ears. Right? Can we go one at a time? One at a time. Come on.
Hills and ricos.
Fever with chills and rigors. Excellent. Atif, what did you mention?
Also prolonged.
Prolonged fever. Okay. Fever with chills and rigors. Yes. What I want you to do, high swinging fever, guys. We call this a high swinging fever. There are rapid spikes, right? Going up, going down, going up, going down. We call this a high swinging fever, right? This is characteristic of an abscess anywhere around the body, right? So in this perinephric abscess, also same thing. You're going to get high spiking fevers, high swinging fevers. The next important thing in pediatric patients, because these abscesses are quite large and pediatric children, they have a smaller body size, smaller tummy, right? This abscess can start appearing as an abdominal mass. Now, adults, guys, we don't usually see it. It doesn't grow that big. It can. But in pediatrics is where we primarily see it as an abdominal mass. If there is an abdominal mass, if the child is complaining of abdominal pain, plus if there is high swinging fever, and the child has had a history of UTI, you must consider perinephric abscess. Okay, right? Understood. Right? In that case, we must do a blood culture. Blood culture must be done. Okay, right. Then, right, final stretch. Look at this. What are the other things we can do? Yes, we can do a renal function test. You all know about this, especially if the child is pyelonephritis, right? Pyelonephritis, we must make sure that there is no renal damage. Later, we will talk about there can be renal scarring, and there are special investigations, special scans we can do just for scarring, right? We'll talk about those in a different class. Just know you all can do the renal function test, serum creatinine, blood urea, serum electrolytes, right? And blood culture, as we mentioned, right? Then, guys, coming to the treatment, look at this. How are we going to treat the child, right? Look at this, guys. When we come to the treatment, first few points I want you all to know, right? Based on the site we already mentioned, guys, if it is an upper UTI, it's going to be an emergency. Right? So here in the upper UTI, we are going to go for what? IV medications. Okay. Whereas lower UTI, we can go for oral, right? For oral medications, right? Then based on the clinical presentation, what do I mean by that? If it is a complicated or uncomplicated one. If it is uncomplicated, we said we can directly start empirical therapy and we can discharge the patient, right? Then, guys, we tell the patient, right? If there is no improvement, this is for adults especially, if there is no improvement, you come back. If not, if the symptoms disappear, no need to come back for follow-up. Simple UTIs, no need, guys. No need, right? Only if there is no improvement within 1 week, come back for follow-up, right? And then patient advice and education, right? We'll talk about this in a little bit, right? The next thing, guys, complicated UTI, what should we do? We will again start empirical therapy, right? Before the culture results come, we will start, but we must do the culture. That's what we mentioned before, right? And once the culture reports come, we can modify the treatment as needed, right? Okay, right? Then, guys, right? Look at this. Let's go a little bit more specific, right? What do we mean by this? What are these treatment based on site, right? Let's start with upper UTI. If we are suspecting a patient of having upper UTI, right, we are going to go with IV medications. IV, write this down, CAG-Q, right? IV, CAG-Q. What is this CAG-Q, right? Just for you all to remember, right? Okay. What is this CAG-Q, guys? Right? The C. What is this? Cephalosporins, right? So cefotaxime, right? Ceftriaxone, right? Ceftriaxone, these can be used, right? Okay, third generation cephalosporins, basically, right? Cefotaxime or ceftriaxone, right? Then A is what? Augmentin. What is this augmentin? Our co-amoxicillin, right? Augmentin, co-amoxicillin, right? Co-amoxicillin. I don't want you all to know the doses here, guys. For the MBBS level, right? No need doses, huh? No need doses here. There are some conditions where we need doses. This UTIs, no need doses, okay? Right? Next thing, what is the G? Gentamicin. What is this gentamicin, guys? What is the drug class? Antibiotic class? Aminoglycoside. What is the important thing about gentamicin? Important side effect? Nephrotoxicity and?
Ototoxicity.
Ototoxicity. Here, right? ototoxicity, nephrotoxicity and ototoxicity, right? Okay. Atif, which year? Which year are you in?
Final year.
Final year. So you're intern or you're still studying?
Actually, we finished our internship now. Like we're back to do some mixed practicals.
Okay.
Due to
Excellent.
COVID.
Excellent. Right. Okay. Good. Right. Then, what is the Q, guys? Quinolones. What are these quinolones, guys? Especially one common one is ciprofloxacin. These quinolones, guys, we don't use in pediatrics. Huh? We don't use in pediatrics. This is for adults. The rest of the stuff, what we have talked about, right? The third generation cephalosporin, augmentin, gentamicin, we can use in pediatrics. Gentamicin also you have to be very careful when using, right? But we can use. Quinolones, we don't. Use. Ciprofloxacin, we don't use. It's only for adults. Why? One thing, allergic reactions are high. The other thing, guys, these quinolones are known to cause arthropathies, right? There can be cartilage problems, right? Bone deformities, these kind of changes can be there, right? Okay. Then, lower UTI. How are we going to treat? Oral, can't, right? So IV CAG-Q for upper UTI and for lower UTI, oral can't, right? Okay, oral can't. Now, what is this? Again, here guys, the C, right? Again, cephalosporins, but first generation, like something like cephalexin, right? And A is again our augmentin, same one, right? N, what is this N, guys? Nitrofurantoin. And there's another one, nalidixic acid. This nitrofurantoin and nalidixic acid, right? Nitrofurantoin, what is this, guys? This one is one of the most specific drugs for UTIs, right? A couple of years back, this was actually the first line. Now it has dropped down a little. A couple of years back, this nitrofurantoin was the drug for UTIs. Okay. Now it has dropped down a little. This one, guys, it inhibits bacterial DNA synthesis, right? Nitrofurantoin. That's how it works, right? Nalidixic acid is what? What is nalidixic acid? What is the drug class? Nalidixic acid, guys, again, it's under quinolones. So we have to be very careful. We usually don't give it to children, right? It is also quinolone, right? Then, the other one, right? Can't, right? The T, trimethoprim plus sulfur methoxazole. What is this trimethoprim plus sulfur methoxazole combination called? We call it together co-trimoxazole, right? We call it co-trimoxazole, right? Co-trimoxazole, right? So these are our main option, guys, based on the site, right? This I want you all to remember. You must remember this, right? Especially for your pediatrics, you must know this. Okay, these names. I don't want the doses, right? Just the names, right? Then, now what if the patient? Now this is based on the site. We are talking about the upper UTI as well. We said we are going to go with IV medications. And what did we say about upper UTI? This is a bit of an emergency. It's a bit of a, we don't want to, because what can happen after with pyelonephritis progression, guys, child can go into septicemia, right? And then septic shock, right? So we want to manage it before it progresses. So when this is such a condition, guys, we have to go with the IV antibiotics and, right? Here we have to do the general emergency management. You have to check the ABCs, connect the child to the cardiac monitor, look at the pulse oximeter, right? If the saturations are low, you have to put the child on oxygen with a tightly fitting face mask, right? These kind of managements you must do, right? When it is upper UTI, right? The other thing is, guys, now what did we say? We are starting IV antibiotics. And with the improvement of the symptoms in upper UTIs, we can slowly stop the IV and we must continue. Once we stop IV with the improvement, stop IV and then continue oral of those medications for another 7 days, right? This is a must do, right? Okay. We can't just stop the IV and tell them to go home. Okay. Right. And then throughout the management, guys, you must put the child on IV fluid infusions, right? This is to improve the urine output, guys, right? And especially if we are using nephrotoxic drugs, we have to pay special attention. So we will give fluid infusion, okay, throughout the management. This is upper UTIs. Okay. Everyone clear about this? Give me a thumbs up, right? This is a little theory heavy today, right? I know, even for me, when I'm up here, guys, I jump up around a lot, move my hands around a lot. Once I'm seated, little bit, either getting old, liking to sit down for a while. right? Okay. Then next thing, based on the clinical diagnostics. Now, but based on the clinical picture, what do we need to talk about here, right? Complicated or uncomplicated? Look at this, guys. If it is, first let's go with uncomplicated. If it is an uncomplicated case of UTI, now you all know the definition of uncomplicated. Go back at the note and look if you all don't remember. If it is uncomplicated, we said we don't usually need to do the diagnostic investigations. We immediately start with what we call empirical treatment. What is this empirical treatment? Without any lab diagnostics, we are blindly starting treatment. This is what empirical treatment is, right? Empirical treatment for uncomplicated cases, guys, usually by 3 to 7 days, they are fine. Usually 3 to 7 days is enough. 3 to 7 days is enough. Okay. And we start the empirical treatment. We do not keep them in the hospital for 3 to 7 days. Discharge home. Discharge home. They can take the medication at home, oral medication at home. And we follow up if there is no improvement, right? Okay. Here, guys, we said we have to advise the patient on certain things. There are some advices we want to give. What are these advices we want to give? Come on. I am having a UTI. I'm your patient. You all are the doctors, right? Now I'm having an uncomplicated case of, actually, if I have, it's complicated, no? Problem. Okay. Let's imagine I am a female. Okay. I am a female. Now I have come to you. Uncomplicated, very simple UTI. You put me on the medications, right? Some cephalosporins, right? Some Augmentin. And now you're sending me home, right? Before you send me home, what do you want to tell me? As the physician, what advice should you give me? Come on. Anything that comes to your mind.
Fluid intake.
Fluid intake. What are you going to tell about the fluid intake? Advise me properly.
Should have adequate fluid intake.
Have adequate fluid intake. Doctor, what is fluid intake? Just use simple words. Drink a lot of water. Right? How much usually you want to tell the patient? Usually about a 2-liter bottle per day. If you can finish, it's good. Right? 2-liter large Coca-Cola bottle or something. If you have at home, fill it with water. Drink for 1 day. That is good. Right? What else? Okay. Drink a lot of water. Okay. What else? Drink a lot of liquids. What else?
Maintain perineal hygiene.
Okay, good. Maintain hygiene. What specifically do you want to tell me about hygiene? How are you going to? Y'all can't just tell this, good fluid intake, maintain hygiene. No, okay, not in my class, right? Now imagine you're with the patient. How are you going to advise, right? About the hygiene. Come on, Atif, you can. What are we going to say? One thing, wiping direction, right? Wiping, you all know the tissue, you all have to wipe now. What is the wiping direction? Front to back or back to front? How do you want to advise the patient to do it?
Front to back.
Front to back, right? Now, based on the anatomy, we've discussed the anatomical structures. We don't want the pathogens in the anal region coming and migrating to the urethral orifice, right? So front to back. Okay. Anything else about hygiene? Come on. Let's say, okay, I was here, uncomplicated UTI, I'm a female, right? 25 years old, newly married, and you all diagnosed Staphylococcus saprophyticus on me. Anything else about hygiene you want to mention? Come on. Guys, voiding after intercourse. They must urinate after intercourse to try and wash out any pathogens that might have migrated in. Right? Voiding after intercourse and voiding before bedtime also. Because during bedtime, you all know you all are in bed for 8-9 hours, right? And there is a relative stasis. Urine is not moving. When urine is not flowing, urine is not moving, again, high risk for colonization. So voiding before bedtime and voiding just after intercourse is a must. You must advise these. Okay? Right? Okay. Dinita, your third year, yeah? Dinita? Third year. So, for you all, have you all had do you all have the short case and the long case separate, or do you all have them together like one large examination?
Separate.
You all have it separately. Okay. Right. Okay, good. I just wanted to know that. Right. Then, what else, guys? Okay, so you all advised me on high fluid intake, about the voiding, right? Anything else you all want to tell me? Now, we talked about at the beginning of the class some risk factors. Lula, anything else? Right? Avoid bubble baths, right? Avoid bubble baths, right? Yeah, avoid bubble baths. Okay. Avoid bubble baths and any spermicidal gels also, right? Try and avoid during this period. Okay. Then, guys, There is another one. Have you all heard about cranberry juice? Right? This is also under research, right? But very interesting what they have found out, right? There's this compound called proanthocyanide. I don't know if you all have heard. There is a benefit that they found. There is a benefit that they found with this cranberry juice. So you all can suggest that also. Now, in rural areas, you all can't tell them to go find cranberry juice. Okay? They'll be like, doctor, I don't have money to buy cranberry juice, right? Just, but you all can suggest, depending on the clinical setting where you're practicing, right? You all can do that. Then, so those are the things about the uncomplicated one that I want you all to know. If it is complicated, what did we say, guys? Complicated. We are going to do empirical therapy, but we must do investigations. We must do investigation, right? The choice of drugs we've talked about. Here, guys, what I want to tell you all, we tell the patient to come for a repeat urinary culture, right? Repeat urinary culture 5 days after starting the management. Remember when we were talking about that relapse, reinfection, and treatment failure? Within the first week, we told the patient to come. This is that. By the 5th day, we tell the patient to come for a repeat urinary culture. We want to see if the antibiotics are working. Right? Uncomplicated ones, we don't care. Take the medicine, go home, sleep. Right? Don't come again if there is no problem. Complicated ones, come back in 5 days. 5 days. Right? Right. Then, guys, if it is complicated, the empirical therapy that we are going to give. Now, we've talked about the drugs of choice. The empirical therapy, whatever drug we are going to give the patient, if it is an adult, right, and even children, right, adult or children, we usually treat for about 7 to 10 days. Usually around 1 week to 10 days is necessary. For children, guys, just note 7 to 10 days or 48 hours afebrile, whichever comes first. Either they can be afebrile, no fever for 48 hours, or 7 to 10 days, you continue the medication. Whichever comes first, you can stop the medicine. Okay. Right. And for complicated cases, as we said before, right, after the patient's initial condition is settled, we must investigate for other underlying possible causes. Okay. Right. Then this one. Now, this is very important, right? Even this time, final MBBS paper, this was there, right? You all must know management of pregnancy, right? UTIs. In genomes, we're talking about genomes, right? You all must know for genomes, right? Right? Let's take a look at this case because I don't want to talk about entire UTI and miss pregnancy UTIs, right? Just because it's genomes, right? So we'll talk about that also a little. Look at this. What did we say most commonly in the 3rd trimester, guys? The most common species is group B strep, right? Everyone is now familiar with that. Here, what do I want you all to know? If you look at the epidemiology, right? I put it here. You all can just read 25% of pregnant women will get symptomatic UTI. 15% of pregnant women will get asymptomatic bacteriuria or asymptomatic UTI. Now, if it is an asymptomatic UTI, how do you know that it is a UTI? If the patient is not coming with symptoms, how or why do you know that this is a bacteriuria in a pregnant mother? Huh? Magically, when you see the mom, you know, asymptomatic bacteriuria. How? Come on. Why, guys? Why? Because you all know routine antenatal care, we must do UFRs, right? You have to do urine culture and UFRs, one in the booking visit, right? Booking visit we must do. This is your community medicine. These guidelines, community medicine guidelines change almost every 6 months. So before going to the exam, make sure you go through the relevant necessary guideline and go, right? Okay. Exam questions will come with the most up-to-date guideline. Okay. So you should know the most up-to-date guideline, right? Especially Sri Lankan students, you all know the true or false paper. Not very easy, Okay. Right? And failing community medicine, one of the worst things that you all can do to yourselves. Okay. Right? Okay. Dinitha, which year do you all have community medicine in?
As far as I know, it's tested even in the last year.
Tested even, when do you all start?
3rd year.
3rd year. So you have already started community medicine, yeah?
Yes.
Okay. Right. Good. Right. Now, here's what I want you all to know, guys. When it comes to pregnancy, there are some guidelines by what we call this RCOG, right? Royal College of Gynecologists and Obstetricians, how to treat this. Look at this. Write this here. Let me take it here. I will take it down here. Right? When we are talking about management, there are 2 main things we want to do. Right? Look at this. One thing we want to do is manage the mother. Treat the mother at the time of diagnosis. Right? Let's write this exactly like I'm writing on the right-hand corner of the page, because we are going to use this left space a little bit. Right? Okay. So treat the mother at the time of the diagnosis is the first thing we will do. Second thing is, guys, write this down. I will explain. there is something called intrapartum antibiotic prophylaxis. What is this intrapartum antibiotic prophylaxis? What do we mean by intrapartum this? What is the word intrapartum? What do we mean by that? What does partum mean? Partum. Huh? What does the word partum mean?
Pregnancy period.
More than pregnancy, we are specifically talking more about childbirth. We are talking about the birth process, right? That's why we have postpartum hemorrhage, right? The birth process, right? Intrapartum antibiotic prophylaxis is, guys, during labor, write this down somewhere. During labor, we are going to give IV antibiotics to the mom, right? To the mom, in the aims of protecting the child from getting the infection, right? We are going to give IV antibiotics. We are going to give it via IV route to the mother. But our aim is to prevent the child, the newborn child, developing sepsis, right? To prevent it. Okay. This is IAP, right? Your textbooks will call it IAP, intrapartum antibiotic prophylaxis, right? Right. What is our drug of choice for intrapartum antibiotic prophylaxis, guys? We go with first choice is benzyl penicillin IV, right? Benzyl means IV anyway. Benzyl penicillin, right? Benzyl penicillin, right? Here, if the mother is allergic to penicillin, right? If the mother is allergic to, again, there are some variations, guys. If the mother had a previous allergy, which was mild, we can go with cephalosporins. If it was severe, we can go with other drugs. There are variations like that. Just remember, if the mother was allergic to penicillin, our options are cephalosporins or vancomycin. Right? Cephalosporins or vancomycin. Just write that down. Benzyl penicillin, you must remember, right? Now, when do we do this number 1 and number 2 treatments? When do we do them together? When do we do them combined, right? Let's take a look. What are these indications? First one, right? If the mother, write this down, if the mother is asymptomatic, mother is symptomatic, right? Mother is symptomatic. Plus, when you do the culture, it is positive culture, right? Mother is symptomatic and there is bacteria that you found in the urine sample, culture positive. Then, guys, you must, at that time of diagnosis, let's say the mother came to you in the 30th week of pregnancy. At that time, you must immediately manage the mother, treat the mother. And let's say at 37 weeks, the mother goes into labor. At that 37th week, when the mother goes into labor, you must give the intrapartum antibiotic prophylaxis, right? To protect the baby. You have to do both. Okay. Right? Understood? Second scenario. If the mother is asymptomatic, what is this asymptomatic mother? She doesn't have manifestations, but culture positive. We call this asymptomatic bacteriuria. That means she is not showing symptoms, but if you look at her urine, the bacteria are present, right? If the mother is asymptomatic and she is having a culture positive, then you look at the number of colony forming units, guys. If the colony forming units are greater than or equals to our usual 10 to the power 5, or what is the other possibility? CFU less than 10 to the power 5. All right, give me a second, guys. Guys, can you all see me? Huh? Okay, very sorry. Right. Let me connect the screen again. Right. Big problems, guys, huh? It's okay. What to do, right? Can you all see the screen? All good? Yeah? Right. Yeah, sorry about that. Okay, so what were we saying? In the case of a mother who is having asymptomatic bacteria, if the colony-forming units are more than 10 to the power 5, right? Or colony-forming units are less than 10 to the power 5. What are we going to do? If it is more than 10 to the power 5, guys, we have to again do both of these, right? Treat at the time of diagnosis and intrapartum antibiotic prophylaxis during labor, right? Okay. If the colony-forming units are less than 10 to the power 5, at the time of the diagnosis, RCOG recommends that we do not need to treat the mother. However, we must treat with intrapartum antibiotic prophylaxis during labor. Right? Okay. Right? Understood? Then guys, the third scenario, if this is the second child, that means what? Previous child was infected with GBS soon after birth, right? Or sepsis soon after birth due to GBS, right? If that is the case, right, what should we do, right? Even if the mother is not positive in this pregnancy, even if the mother is not having a UTI in this pregnancy, we still do this intrapartum antibiotic prophylaxis during labor for this pregnancy. Understood? Then guys, the last condition here, right? Last condition, just for you all to know, if it is a planned cesarean section, and the mother is currently not in labor, right? And the membranes are intact, right? And she's having a UTI. All this plus she's having a UTI. If this is the case, regardless of the GBS state, we don't care if she's a carrier of the group B strep. Regardless of the GBS state, right? We usually, since this is a planned cesarean section and this is more in our control, right? We can, no need to give any of this. No need intra IAP. No need IAP. Okay. Like a Torana, no? Right? Lights going, coming back. Okay. What to do? Right? Okay. Understood.
Can you explain the fourth one again, please?
The fourth one, yes. If this is a planned cesarean section, right? Now, let's say the mother is coming at around the 36th week and you have planned the cesarean section date within the next 2 weeks, right? Here, we do not need to give, and the mother is having a UTI, and there is no membrane, there is no rupture of membranes, right? And the mother is not currently in labor. If this is the case, we do not need to give intrapartum antibiotic prophylaxis. Why, guys? We will manage the mother, right? We will check the mother. If she's going into pyrexia, if she's going into shock, we will manage in that direction. But we don't need to manage the child at that moment if it is a CS, if it is a C-section. Why? We can take the child out immediately, and the risk of the child now, because this is in the urinary tract, guys, the GBS is in the perineal region, right? The group B strep is colonizing there, right? Around the vagina and now in the urinary tract. So if this is not a normal labor, it is unlikely that the child will get it. However, right? Since we are doing a CS, right? We don't really need to worry about it too much. So we don't need to give intrapartum antibiotic prophylaxis. This is one of the only instances where we do not give intrapartum antibiotic prophylaxis. Okay. If you see all the other instances here, we give intrapartum antibiotic prophylaxis. Okay. Right. So remember this. Very likely to be asked. This is a new guideline, right? Quite a new guideline. Not very new. It's been there for a while, but you have to know this. You have to know this. Is everyone clear with this? Right? Everyone understood? Right? Okay. Now, guys, right?
Excuse me, doctor.
Yes.
In fourth scenario, when are we treating the mother?
The mother's treatment, guys, so there is no guideline for the mother's treatment. That will depend on the mother's current status. If she's going into sepsis, we might need to treat her. If she's stable, if she's fine, right? And the C-section is today evening. This is a clinical judgment. If the C-section is today evening, you don't need to start now, right? Like that. That part, don't worry about it too much. They won't even test you all in the exam, right? That is a more senior clinical decision, right? But what we should know is that we do not need to give intrapartum antibiotic prophylaxis to the child via the mother's IV route, right? Not needed. That information you must know. Okay, right? Okay, clear up to this point. All good. Hey, give me a thumbs up. I know today's content is very heavy. We are done, guys. We are done. One summary I will give you all, and plus one more point, guys. Just know in your pediatrics, you must a child coming with UTI, you must suspect child abuse, right? You must suspect child abuse. So if you are suspecting child abuse, what should you do, right? First thing, admit the child to the ward. If there is any suspicion, you don't want to send the child home. Why this child can go home and get abused again, right? So admit the child to the ward is the first step if you are suspecting child abuse, right? Then you must do the necessary referrals. What are these necessary referrals, guys? One is gynecologist, right? Immediately. STD referral must be done. STD, right? Then you must also call, right? Depending on the severity, you might need the judicial medical officer coming, right? And psychiatry referral as well. Psychiatry referral as well. All of these are needed. All of these are needed. And then there is the case discussion, guys, you with the hospital director involved, right? To decide. You all will learn this in community medicine and pediatrics also, where you are going to decide if to send the child home with the parents or what you are going to do next. Okay. So immediately admit the patient as your intern officer, as a housing officer. Your job is immediately admit the child. And the next thing, inform the seniors and start the reference. That is your main job, right? Okay. The final step is the case conference, right? That is the one I said we all talk with the hospital director together, right? The child's family, right? All of the police will also come, right? The hospital police will also come, right? All of that is there, right? Then the other thing about phimosis and labial adhesions, how to manage, guys, for phimosis. This is again in your pediatrics. Phimosis, we said, but inability to, right? Retract the foreskin. What are we going to do? What are you going to do? Let's say a 1.5-year-old child coming in with, mother is bringing with complaints of phimosis. What are you going to do? What are you going to do? Come on. Immediately going to cut and chop? No, right? Until 3 years of age. Until 3 years of age, you can advise the mother during showers, you can retract the foreskin a little, right? If there is any inflammation, if there is any reddish appearance, you can apply some anti-inflammatory ointments, some creams, right? Some hydrocortisone or something like that, right? Until 3 years, you can try home-based things. After 3 years, if the phimosis is still not corrected, if it is still very difficult to retract the foreskin, right? After 3 years, guys, it starts thickening up. So we do not want then, if the child is more than 3 years of age, we go for circumcision, right? 3 years of age. Then the other thing, right? Labial adhesions. Labial adhesions. How are we going to solve that problem? Why is this labial adhesion happening, guys? You all know, right? Embryonic development, right? The labia must separate step by step. What is happening is if there is immature, if it is not developed properly, only the adhesions will be there, right? So what we are going to do, guys, we can apply some estrogen cream, right? In the central line along the adhesion, right? In the central line where the adhesion is there, we apply estrogen cream around 2 to 3 times per day, right? For about a month. Usually it will improve, right? Usually it will improve. Okay. What are the side effects of estrogen? When you're giving it to a baby, when you're applying it on a baby, one thing. Come on. Huh? What are the side effects of estrogen when you apply it on a baby? Huh? Come on. Huh? Write down. Breast budding can happen, right? Breast budding can happen early, right? The other thing, pubic hair growth can occur. Some secondary sexual characteristics based on the amount of estrogen that has been given. This is why, guys, it has to be properly monitored. You can't just start applying estrogen for a long period of time. It's a very short course, right? Usually by a month, we need to taper off and stop it. Okay? Right? Okay. Then, guys, that's that for here. Let me give you all a small summary, right? Write this down. This summary, if you have it written down, that is all you will need, right, for your UTIs. Write this down. We are getting a patient, right? We are getting a patient. You all can see me, right? You can see I'm writing, okay? We are getting a patient coming in, right? What is our first question, guys? Is the patient symptomatic, right? Let's say, let me write it, symptomatic. Is the patient symptomatic, right? This is our first question. Is the patient symptomatic? Okay, symptomatic. Let me take a different color, guys. Yeah, is the patient symptomatic, right? Different mark. Now, what can be the answers? Yes or no, right? The no side, we will leave it. The no side, we will leave it, right? Yeah, we are going to talk about this asymptomatic bacteriuria and all of that. If the patient is symptomatic, right? What is our next question, guys? Based on the symptoms, is this the upper UTI or a lower UTI, right? That is our second one. Upper or lower? That is the next question. Upper or lower UTI, right? Upper or lower UTI, right? Clear? Now, take another color. Okay, upper or lower UTI. Now, let's check. What are the options? It can be here, I will say lower. Here, upper UTI. Right? If it is a upper UTI, what is it? What do we do? Admit the patient. Write down. Admit the patient. Admit the patient. Because these are emergency, no? Admit the patient. Right? And we are going to start empirical therapy, but we must do diagnostic investigation. We must do the urine culture. And what are we going to give as medication? IV antibiotics. IV antibiotics. Okay. Clear? Right? Then the next thing, this side, lower UTI. If it is a lower UTI, what is our next question? If it is a lower UTI, what is the next question? Is this complicated or not? Complicated or not? This is our next question. If we are suspecting the lower UTI, right? Upper UTIs, anyway, it falls under complicated cases, right? That's why we admit the patient and do all that stuff, right? Lower UTI, our next question, is it complicated or not? If it is or not, look at this, yes or no. Let's say this side is yes, this side is no. So yes means what? It is complicated. No means it is uncomplicated, right? If it is yes, that means what? It is a complicated case. What should we do? Diagnostic investigations. Do the diagnostic investigations, right? Do the culture, right? Start empirical antibiotics. Empirical management we start. When the culture report comes, depending on the culture report, we can either add more medications, we can change the drugs, we can do all of that, right? Okay, right. Then guys, now let's say the culture results came. Here, we are still in this complicated side. Huh? You send the urine for the culture report and you started empirical treatment. When the culture comes, the next question is the culture positive? Is the culture positive, right? Is the culture positive? That's the next question, right? Here, what can we have? Again, yes or no, right? Yes here, no here, right? If the culture is positive, what does that tell us? Diagnosis is confirmed. Diagnosis is confirmed. Diagnosis of UTI is confirmed, right? And we continue the treatment, right? Continue the treatment, add drugs if needed, reduce the drugs if the patient is improving, whatever, right? Here, when you check the culture, if the culture is not positive, what does that mean? Culture is negative. What do we do? Come down here, right? Lower UTI, complicated case, right? You do the diagnostic, you send for culture, culture report comes negative. What is our next step? What do you all think? Come on. Tell. Doctors, answer. Culture report coming negative. What are you going to do? Repeat the culture. Repeat the culture, right? Okay, repeat, very easy, guys. Repeat the culture, right? Repeat the culture. Now, you repeat the culture and it is still negative. Still negative. Repeat the culture and it is still negative. What is your diagnosis? Start from the top. Symptomatic, right? Coming all the way here. Culture done twice, negative. What is your diagnosis? Unmute and say, I mentioned this in the class. Symptomatic patient, culture negative twice. What is this? Come on.
Urethral syndrome.
Excellent. Urethral syndrome. This is urethral syndrome, guys. If that is the case, now we have to start looking for other causes, right? Everyone agree up to this point? Okay, right? Okay. Look here. Now here at the complicated, we went down the yes side. Complicated one, it is not complicated. The no side here. If it is not complicated, what do we mean by that? Non-pregnant female of reproductive age, non-recurrent in nature, and no other disease association, right? Everyone agrees? That's the uncomplicated one, right? If that is the case, what are we doing? Are we going to do diagnostic investigations? No. Spot diagnosis. We call this a spot diagnosis of UTI. So spot diagnosis of UTI. Start empirical antibiotic therapy. Start empirical antibiotic therapy. And send the patient home. However, right? What do we tell the patient? By 1 week, if it doesn't get better, come back. So follow up in 1 week. 1 week. If it doesn't get better, remember, if it doesn't get better, we don't tell all the patients to come. Just if it's better, it's fine. They can stay at home. If it doesn't get better, 1 week, come back, right? So this is the next question. By 1 week, is the patient better or not? So let's say yes on this side, no on this side. Patient, yes, is better. If he is better, does he need to come? We don't even want him to come to hospital. So you do nothing. If he is not better by 1 week, what should we do? We manage this patient as a complicated case. This goes all the way here. And we come down this, right? Okay. We manage this patient as a complicated case. Okay. Right. Understood. Did you all understand what we are doing to a symptomatic case of UTI? All clear? Give me some thumbs. Right. Okay. Now we'll come to this side. The symptomatic patient, first question was, is the patient symptomatic or not? This is no. The patient is not symptomatic, Now, when are we getting asymptomatic patients, guys, that we are suspecting of a UTI? What is one example that we already discussed in class? Come on. Last week.
Asymptomatic.
Pregnancy. Excellent. Pregnancy. In pregnancy, right? We are going to test because there are routine investigations we are going to do in antenatal care. Booking visit, 12th week, 16th week, sometime again 20th to 24th week, there is another test. Like that you have to do, right? So pregnancy, you are going to detect in their urine sample accidentally, right? Patient is asymptomatic. Accidentally, you are going to discover that they have bacteria in their urine, right? Okay. Pregnancy is one. Then guys, any other example that you all know of? Any patient that is about to undergo a urologic procedure, any urologic procedure, be it a stenting, be it a surgery, whatever. Any patient before they undergo a urologic procedure also, we want to do a urine culture. Right? So that is your second scenario where we get this asymptomatic. They are asymptomatic. They are not showing the symptoms, but you do the culture because it is routine before their urologic problem, before we do the urologic procedure, and then you find bacteria. They are asymptomatic. You do the culture, accidentally you find bacteria. Right? That is your second example. Any patients pre-operate, right? Before any urological procedure. So what are we going to do if the patient is asymptomatic and you see bacteria in their thing? What do I mean by that, guys? We are doing the diagnostic. We are doing the diagnostic test. No, that is our culture. We do the culture. In my mothers also, we do the culture. Before they go to the urologic procedures also, we do the culture. What is our question? Is the culture positive? This is our question, right? Look at this. Is the culture positive? If it is yes, what is it? Patient is asymptomatic, but culture is positive. That is asymptomatic. Guys, can you all see me? Can you all hear me? Very sorry. Router is also going to die today. Right? Look at this. Where did I go off? So we started off here. Patient is asymptomatic, right? We did the culture. Now our question is the culture positive or not? If the culture is positive in an asymptomatic patient, asymptomatic bacteriuria, right? Okay. Was I there after that? Or did I go before that? I was there, right? Okay. Cool. Right? Asymptomatic bacteriuria. What is the other one? Right? Patient is asymptomatic. You do the culture. Culture comes out negative. What should you do now? What should you do next? Come on. Good, Imesh, good guess. But now see, patient is asymptomatic. Patient doesn't have symptoms. Culture is negative. Do we need to repeat? Not really. Right? Here, guys, we do nothing. Okay, patient is asymptomatic. Now here we repeated why patient was symptomatic. Patient is symptomatic. When the patient is symptomatic and culture is coming negative, we can suspect that, okay, maybe there was a problem with the culture sample. That's why he's not showing a positive culture. Here, if the patient is asymptomatic and the culture is negative, no need to do again, right? Unless it is a very strong indication, no need to do. Okay, right? Okay, good. Now, so this guy is nothing. If it is asymptomatic bacteriuria, what is your next question? Is the patient pregnant? Okay. Here also, yes or no. If the patient is pregnant, right? What do we don't need to write everything here. Just write RCOG guidelines. Now you all know how to treat asymptomatic bacteriuria in a pregnant mother. Right? Okay. If it is asymptomatic bacteriuria and the patient is not pregnant, what do you want to do? Come on. Tell. Come on, guys. Asymptomatic, non-pregnant. There is a special
Uncomplicated.
Treat as uncomplicated. Why? No, good. Okay. Here, guys. Now, if the patient is asymptomatic, there are no symptoms, and the patient is having just a little bit of bacteria in the urine, right? Do we want to, and the patient is non-pregnant, right? Here guys, again, nothing, right? Again, nothing. If the patient comes with symptoms, right, you can do some follow-up. Now, even here, if the patient has a pre-existing condition, let's say there is some anatomical defect in the urethra, then there is an indication to do some further investigations. Otherwise, again, nothing. Right? Asymptomatic, right? We start from here. No symptoms. Did everyone understand this? That's it for this session, guys. Right? I know it was long, right? I usually want to finish my lectures before 3 hours, but yeah, today. But I hope you all learned something, right? Rather than just memorizing content, I hope you all are familiar with UTI now. Okay? Now this is UTI. This is absolute MBBS level. You don't need anything more than this for UTIs. Okay? Right? Coming to the pediatric side, there's a little more to talk about this vesicular reflux, posterior urethral valve, and these kind of conditions. Apart from that, this is 100% UTI. Huh? Nothing else to know. So I hope you all had a good understanding, guys. If there's any question, drop me a message. If you all have some feedback, again, drop me a message, right? Anything, right? Anything, how I can improve, right? If you all hate the lecture, if you all love the lecture, just let me know, right? Dinita, you are actually one of my first local university students. So I'm very happy to know you also, right? Just let me know if you have any feedback, right? Sri Jayavardhan, no? Japura, right? Excellent, right? So let me know if there's anything I can improve. Now, the next session is on 14th and 15th. 15th is, we are getting a doctor coming in. He's actually one of my close friends, right? He's working in the US now, so you all can come and listen to his session. Also, the management guidelines, especially heart failure, guys, management guidelines are a little bit different in the US. So you all can, get a good idea about that as well. So that's about it, guys, right? I hope you all had a good session, right? I will catch you guys in the next one.